Test and stream. 1, 2. Test and stream. 1, 2.
Y'all ready? Call it to order at 8:10 hours. Opening prayer, Leanne. Where's Leanne hiding? There she is.
Will you please join me in prayer? As we gather this morning on this fresh Friday early in 2020, we ask for clear vision, for clarity. Let us see the needs and opportunities before us. Let us see and honor different perspectives among us. Let us see ways that we can come together for the common good. And let us never lose sight of the privilege it is to serve the needs of those who need us the most. Our patients, our community are counting on us. It's in your holy name that we pray. Amen.
Amen. Join me in the pledge.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
JR back there? There's
nobody.
There's nobody?
Well, there are people back there, but nobody signed up.
Okay, just want to make sure we're on the same page. There's no citizens wishing to address the board. We're here for one item today, and that is to hear from at least two people, is my understanding. Two presentations, and I'm going to turn it over to Trent. It's your meeting.
Thank you very much, Mr. Chairman. And Mr. Emerson and I will kind of jointly answer questions and guide the board as necessary today. The opportunity that we had to sit on the interview panels is appreciated very much by each of you. So anyway, we had some very dedicated and talented professionals assist us with this process, which was very helpful. I think Ralph will agree. We also had our COO, Karen Duncan, help us with this process, which was very good. Karen, thank you for your efforts. At the end of the day, we had 8 firms that we spent a great deal of time reviewing. There was a very empirical process laid out that gave us an opportunity to individually score these 8 applicants as well as collectively. So we did that, and we spent the better part of the day doing that. There's well over 1,500 pages of proposals that were ultimately submitted. Each of the firms, very, very qualified, very impressive, very talented group of individuals that, frankly, JPS should be honored to have entertained, because in no case was this something that people did not take seriously. This was extremely important. You could tell by every one of the applications, every one of the proposals. So our job was fun in that we had to go through that level of commitment and talent and narrow this down for today. But at the end of the day, we did come to 2 firms.
This morning to do and deal with our microphones. Is there any that you all have in your chapters?
Is that better? Can people hear me? Sorry about that. It was blinking, and so I wasn't paying attention. So at the end of the day, there were 2 firms that we chose to bring forward for interviews by the board. And as we explored that process, we thought it just made more sense to offer every board member the opportunity to come and interview these applicants. So there were 2 that rose to at least the empirical standard relative to the committee's work that merited the interview. There are certainly others that are, again, qualified firms. And at the end of the day, we're going to be asked to make a recommendation to the Commissioners Court, And Mr. Emerson and I will deal with that when that time comes based on the committee. But for today, we have 2 interviews that we like to conduct. This is structured in a way that we've asked the applicants not to do lengthy PowerPoint presentations. This is really much more about them being able to present their qualifications and their understanding of the scope of this project, and more importantly, to give board members an opportunity to ask questions relative to those proposals. So this is really more about board members becoming comfortable with this process than it is about being an audience listening to a presentation. It's much more about the board asking questions. So any questions of board members before we bring up our first proposal? Ralph, anything I missed?
No, I would just say to the board, those who are on the earlier review committee, when we got down to the home stretch, our eyes got dim from reading so much. But it's key that board members could probably see some things we didn't see that might help us when our final decision.
Great. So we've allocated 45 minutes to an hour for each of these interviews, and hopefully we don't go over that because we have a second interview following this one. So we'll take a short break after the first one and let the next group regroup and put their proposal together. So without any further ado, unless there's questions, we will introduce our first applicant, which is Levis, and whoever is going to be in charge of giving that presentation, welcome.
Good morning. I am Monica Bailey Jackson. I am President and CEO of Levis Construction and Consulting. On behalf of Dr. Broadus and myself, we'd like to thank you so very much for having us here today. Dr. Broadus and I got together a year ago and we formed our JV. We have 32 years of having offices right here in Tarrant County, 32 years. We also have $1.4 billion worth of work that we have exceeded and committed and worked on over the past years here at Tarrant County. Dr. Broadus' company is a hub company, and our company is a hub company. And we are proud to say that 91% of our fee will go to hub companies, and they will go to MWBE firms. Behind me is our dream team, and we're going to dive into that in just a few minutes. But I would like to say that what we did was we took national firms. I'm sorry. We're not over yet. It's not 45 minutes. We took national firms, and we paired them with local minority firms. And what this does is it builds capacity for our local minority firms right here in Tarrant County, and it also gives them healthcare experience. So we're excited to be here. On behalf of Dr. Broadus and myself, we thank you. And at this point, I'll let Jerry take over. And one more thing, JPS, we've worked here at JPS. Broadus has worked here at JPS. I've worked here at JPS. And we would love to continue to work here at JPS. So we thank you for this opportunity.
Thank you, Monica. Good morning, everyone. We're very excited and proud to have this opportunity to come before you today, present our credentials and our plan for your program. I wanted to start today by, my name is Jerry Nickerson. I'll be your program executive, so I will be here on a very regular basis working with you on day-to-day. My background is a registered professional engineer in the state for over 30-something years, and done a lot of work in the medical arena, and my last role was to bring a major healthcare program into operation, and we did that successfully. Here today we have a great team. I want to briefly go through why we believe this team will bring the value that you're looking for on this program. We bring an experience-based approach. We have large facility and healthcare program experience. We've done over $7 billion worth of that kind of work here throughout the country and mainly in Texas. We've worked in over 26 counties. There's more there in the slide for you to find and read. Second, we have specific JPS experience, and that's critical to this program. We've been active on the space planning and the Blue Ribbon Committee. We have members that have worked on both, and we've been really working hard over the last year to further understand your needs for this program. And thirdly, we bring a significant value of first-class executive personnel that are familiar with large, complex programs and all the issues that go with making a program successful. And last, as Monica had mentioned, we have a unique mentoring and pairing between Hub and other professionals throughout our organizational structure so that we can leverage those capabilities and assist and help other firms and minority firms at moving forward. And with that, I just want to stress today, I consider this the first kickoff meeting of the program. We are ready to start now. And now I'd like to introduce our interview team that's here today. And I'll be brief, and each of this, they come up during the presentation, will give a further information. The man on the ground is going to be the guy you guys will be working with daily is Derek Walls, our program manager. We're going to have Katrina Keys, who will be managing our diversity and strategic communication. We're going to have Lindsay Withy, who will be managing our strategic planning and working on behavioral health. We brought Karen Baylor to the team, very qualified, and we're excited to have her, and she's going to be working as our thought leader on behavioral health planning. John Souter with Business Analytics will be tracking this program and developing the cost and financial models that we need to evaluate options as we go through the program. We've got Greg Hughes, who will be handling the master planning. Bill Folks will be doing the process optimization, that's scheduling and budgeting and controls. And we have Chris Briggs, who will help with the real estate side of this. Today's topics are your topics. This topic agenda is the agenda that we were given that you want to hear from us, and that's what we're doing today. And I want to stress that this team is purposefully aligned with your mission. We want to be a part of helping you transform healthcare throughout this county. We believe that the healthcare industry is in a formative and transformative stage, and we are looking forward to participating with you in this program in that manner. And quickly, I'll go through this program organization chart. There's a lot to it. I'll be brief here, and we'll discuss this further. It's really set up such that we can communicate and indicate how this integrated, collaborative team will work with you and work with each other as we move through the program. You'll see here at the very top, we have the leadership of the hospital in Tarrant County, whom we'll be reporting to. You'll see where Derek Walls fits in the maroon backgrounds. You'll see those are the IPMO team members that you'll be communicating with on a regular basis. And then you'll also see the blue ribbons spaced throughout the organization. These are the individuals and companies that have worked on JPS programs here in the past, specifically with the master planning and the programming elements and with the Blue Ribbon Committee. And then the bottom half of that, from about the blue line down, is going to be more about the second phase of our program. So we'll discuss that further in more detail. Now I'd like to introduce to you the man on the ground, the man that's going to be here every day, Derek Walls, your program manager. And I specifically like to highlight that he's fourth generation Tarrant County. He has been active with JPS for many years. He started doing work for JPS back in 2000 as a consultant on many projects here. You liked him so much that you hired him to be the director of design and construction, and he did that in that role from 2002 to 2005, and he understands the culture here at JPS. I think he's the right man for this job. Derek?
Good morning. Morning. Good to see y'all. And it's good to be here presenting to the board. So what I want to talk about first is our IPMO office. And so what's outlined in that is the office is really our leadership team. And we bring to that a lot of experience with projects similar to this. And think of that as really our leadership for our team. We have a large team. This project deserves a large team. So the IPMO are the leaders that will direct the team. The other thing that's really important about the IPMO is it's really our communication back to you. And we see ourselves as being just like another department here at the hospital. And part of that, go to the next slide, is our IPMO is really a physical office as well. What we'd like to do is we know that space here in the hospital is pretty limited as far as conference space and things like that. We know how important your time is and all of your staff. So what we'd like to do is have a remote office that's here because we're going to have a lot of meetings, especially over the first 8 months. And so to have a dedicated office, mobile office, you can see a couple of pictures here of other examples where we've got that in place so that we can continue to have our communications and all of our meetings can be right here on the campus, and really a better kind of stewardship of your staff's time. If you think of trying to get in the car and drive, manage through the parking garage, and that's a lot of time that's kind of wasted in driving. So if we have that right here, and we have a real open door office policy too, so anytime you want to come and see what's going on, we're there and we're right here on the campus. So what I want to talk about now is the first 8 months. So what was outlined in the RFP is the first 8 months of our assignment. And that's really fantastic that you have thought about this first 8 months, because a lot of times when we get started on a project, this gets overlooked, it gets skipped, and architects, contractors may already be on board, and then it's kind of a catch-up. So for the first 8 months, what we're going to be doing is really setting the stage, and we're going to be refining the program, we're going to be refining the strategic plan, and refining the master plan. And so that's what's outlined here. We have a lot of team members that on day one, we're hitting the ground running, ready to go. And this team will be working on our diversity outreach program, setting that in place. We'll also be working on our process optimization, and that is really working through the workflow, the approval process with the county commissioners, with your board, to make sure that we understand and we have that documented, and maybe make some recommendations on a project of this size, how we could get that moving seamlessly, because we don't want it to be held up by potential schedule delays and things like that. Then I'm going to bring my planning team up here in a few minutes, but when you see the strategic and behavioral health planning and business analytics and functional space programming, the master plan and scheduling, that's all part of that refresh of the documents that you've already got, but we're going to need to go back. Some of that's dating back to 2014 or so we're going to do a refresh of that. The last thing that you see on the bottom is where we're going to develop our project implementation plan. And that's a process that we'll go through that really sets the roadmap, it sets the stage when we hit the ground running. After the first 9 months that's on your schedule, we think we can improve that schedule. We think that we can get that work done at least in 8 months. We'd like to maybe improve that. So that's one thing that we'll be doing in that first 8 months, is getting our PIP, what we call it, the project implementation plan, developed. And so that we hit the ground running, hiring architects, engineers, contractors, and having that ready to go. And a lot of that work is pretty intense work in that first 8 months, but we're going to get that PIP plan finished. So I'm going to ask our strategic planning team to come up.
Hey, Derek, before you leave, let me ask a question. And remember what I said. This is about us asking questions. So you need to stop and ask questions, all right? Because this is not going to be something we're all going to be able to, synthesize, and at the end of the day, ask 2 or 3 questions. As we have questions, we need to ask it, okay? So here's my first one, Derek. When it comes to the IPMO and your proposal relative to this process in the first 9 months that is supposed to sort of conceptualize the overall plan, one of the biggest issues that JPS has faced is reconciling the fact that we have $1 billion in bond program money ahead of us, and we have extraordinarily limited taxing ability relative to the debt service necessary to pay $1 billion. So one of the criteria that all of us have talked about has been, help us understand the relationship between the IPMO and the first 9 months of this project, and how your firm is going to give us the financial modeling and the comfort necessary to understand that there's going to be operational costs associated with these capital expenditures, that you're going to show us how and if it's possible that we retain a schedule to spend that. And I want to know that now, because from our perspective, the IPMO is really going to be synthesized in this first 9 months to the point that we're going to have to understand. You know, we know we're not going to spend $500 million in the first 2 years of this project. We may not spend it in the first 8 years of this project, because we have a mandate relative to our ability to execute the capital, coupled with our ability to provide the operation support for it. So before we get too deep into more PowerPoint, help us understand how Broadus is going to be able to work us through that process so that we know there's adequate modeling being done, so that when these buildings get built, we actually have the capacity to pay the debt service and operate the buildings as they should be operated. Does that make sense?
Yes, sir.
All right.
So what we're getting ready to show you is that process. So if it's okay, because we've got John Saunder here with Price Waterhouse, and so he's the one who's going to be, and his team will be doing that modeling. And I think what you'll see in this next couple of minutes, and then I can come back and make sure that we answered your question. So if it's okay, I'll let them kind of approach that.
Is John's portion, because this was a little bit gray to me in the program, is John's portion of work relative to the project occurring in the first 9 months, or what is John's deployment in the process? Because John's value probably isn't in question here. It's John's insertion into the process. So if you help us understand that,
Sure.
with John's presentation, that'd be great.
Okay.
All right. I'll shut up.
No, he won't.
We'll follow back up with you to make sure that we answer the question.
Great.
But there is effort, a lot of effort, and he'll explain that in the first 9 months.
Great.
But then setting up modeling for the performa so that we can make sure that as we're working through the project, even when the project is finished, to make sure that our operation assessments and the things that we went into are working.
Great.
So we're going to have that modeling set up, and then it's going to be a tool that at the end of that we can hand to you, but also this team doesn't go away after the first 8 months. Okay? They're part of the process all the way through so that we can do a refresh, so that when you have questions, we'll go back to this team.
Great. Thank you.
Actually, your question is perfect to set up the next series of slides that we've got. I'm Greg Hughes. I'm Managing Principal of Broadus Planning, and my role will specifically be in the programming and master planning component, but also the overall planning coordination. And that org chart definitely shares with you that we've got a wonderful group of consultants that have had involvement with JPS in the past, and I think that's really key. The diagram that you're seeing right now is actually talking about how critical communication is going to be in this process, how managing data and communicating. The key to the diagram is really talking about, you'll see several boxes there, but the three major boxes there include our strategic planning component, our master planning component and programming, and then our modeling for financial. All of those little lines talk about how we're going to be working together, how we're going to be sharing information, we're going to be looking over each other's shoulders, we're going to be translating that data back and forth to be able to align that data and align those strategic plans with each other, so that we're looking at plans that are going to be achievable and that align with your budget, align with your strategic initiatives. And so I think the critical takeaway from the diagram is that our team is going to be constantly communicating and talking with each other. It's going to be a very integrated, very collaborative process, and JPS will be involved in that process throughout. We will constantly be feeding information to you, gathering your info, and being able to factor that into the project as we progress. So communication in that first 9 months is going to be key.
You have somebody on staff that just draws arrows for you. One person that does all your arrows.
Got that perfected.
Because they're very good at it.
it's a cyclical, one of the things you see there with all those arrows is it's very cyclical. We will end up gathering information, we'll end up translating that, we'll end up coming away with specific objectives and specific criteria that we want to try and incorporate into the project, and we will absolutely be sharing that with each other and monitoring that back and forth to make sure that the strategic, the physical, which is that master planning piece, and the financial all are alignment.
Good morning, I'm Lindsley Withy, and I am with Navigant, and I had the pleasure of working with the Blue Ribbon Committee in the last planning phase, working on evaluating prior work as well as the ambulatory network plan. And I'm here today to talk through a high-level process that we have to help facilitate the strategic planning process as well as the behavioral health planning process. So these two processes, while they are separate and independent, they are very much of a collaborative effort, and we'll be working very closely throughout the entire 8 months that we're striving to achieve the recommendations on both of those flows of work. So we have a process, more arrows indicating lots of collaboration and iterative process that we have between all of our team members throughout this engagement. So first, we're going to start with a lot of data gathering. And so with Navigant, we're the third largest healthcare consulting firm and have a robust, not only set of information that we have, but also a lot of SNEs that will be helping to inform this project from a perspective of expertise, not only from behavioral health, but also from value-based care. We also have a tremendous amount of resources that we can help compile the information to inform the baseline of the strategic plan and behavioral health strategic planning components. And so we'll be working very collaboratively, not only with you to obtain data, but we have tremendous data resources. And this will be coupled with data that we obtain throughout the entire district in obtaining input from folks on the ground and throughout the community. And so very important that this will be kind of the baseline of information that will help inform not only the strategy, but also with the financial component, we'll be working very collaboratively with PwC to create the baseline of information that will be feeding our proprietary models. From the data that we gather, this will be the baseline of developing a very robust market assessment for you. So again, between the two streamlines of both the strategic plan and the behavioral health strategic plan, it's a tremendous amount of information that we'll be gathering and compiling into reports, and working with your teams to make sure that we're hitting all of the most important factors that are important to the community and success of this project going forward. So this will be a lot of really understanding the market, understanding the theory of the market, but also looking at best practices that we recognize across the country. We work with systems from coast to coast and internationally, and can bring lots of that thought leadership into the project at this point in time early on, and help set the baseline for when we start going out and talking to the community.
So Lindsay, how does Blue Ribbon history and Blue Ribbon work assist you in that process? Because one thing we ask is, are we going to have to reinvent the wheel every 3 months when we start this process, or are we going to take advantage of what we have?
Absolutely. Yeah, very much appreciate the question, because it's critically important that we have spent a lot of time in fully understanding all of the work that's happened over the last 10, 15 years and how that will inform going forward. And so while we recognize that there's a tremendous amount of work, that will be the baseline of information. We are ready to go hit the ground running and use that information as the baseline, but there is a need for refresh, and we recognize exactly where that is. And so in developing our report, we provided recommendations that it is imperative to have refreshed information to make sure that you're using current baseline information and the best projections that are available in the market, and that we recognize as the highest industry standard to be able to understand where are those growth opportunities, not just at a high level, but by the very specific service lines, and understanding, working with people on the ground in the departments, where are your strategic plans. And it's so critical that you're working together with the strategic plan element and devising what are the goals for your organization and how is that going to project volumes going forward. So what's critical is that we're developing the strategic plan, but that also is going to be informing at a very specific level, very specific detail that will be flowing through all of our models at a very minute level that we haven't seen any of the prior reports. They're gonna help inform what are the growth projections based on very specific strategies that you have service line by service line, that ultimately will inform how many beds that you need on each floor, each unit, by service.
So how often is that strategic plan revised?
So we will be working with your team and we'll talk through the process, but our intent is to help you guys develop that strategic plan, teach you along the way how we go about that process as we do this all over the country, and then enable you guys to take that strategic plan, and it is an iterative process. It should be living, breathing. You should be updating it consistently throughout the process, but we will be here to revise that initially once we're done on a quarterly basis, and then every couple of times a year, but then throughout the entire engagement, where you're here to be accessible throughout the planning, which Derek just alluded to help revise those, be here and help revise those strategic plan, but also enable your team to have the knowledge of how that should be updated on a regular basis.
And Lindsay, will that up to and including, because one of the things that we've all sort of wrestled with is, you know, based on Blue Ribbon, and by the way, Dr. Simmons was on Blue Ribbon, you know, I would ask him to chime in on this. There was a prioritization of projects that emerged from that. And I think all of us have been under the impression that those projects are indeed very important to JPS now. On the other side of the coin, it's very clear to us that the strategic planning process needs to be overlaid on those priorities.
Yes.
So what's y'all's perspective on, you know, the Blue Ribbon product relative to the strategic planning process, and how and if we need to go back and review those priorities?
So what I would say is to have a strategic plan and to have priorities, or the priorities are a component of a strategic plan. But you need to have a baseline of a strategic plan and really understand your mission, vision, values, goals, what are gonna be the objectives of that. And then those are enablers to make sure that you are fulfilling that strategic plan. So we would see all of those priorities as elements within the strategic plan that enable you to achieve what you have as your strategies. So in knowing what those recommendations are in the Blue Ribbon report, we agree that there are very important strategies that need to be executed in a very timely manner and phased appropriately. But those would be enablers to actually achieve the strategic plan. There's much more of a foundation that needs to be driving those enablers.
And do mission, vision, objectives, what role does the board play in that? Because we've all gone through, over the years, various iterations of strategic planning.
Yep, you wanna just flip a couple slides forward, and we will come to this.
And I don't want to get you out of order.
No, that's okay. No, I think it's fine, because we want to make sure we're hitting on what, so we will be with you, working with your team, and we will determine that on the onset how best to approach who's going to be involved in these discussions. But this, when we're getting ready to determine what the strategic framework is, we're going to establish work groups and have facilitated sessions that will be, once we've obtained our data, will be the foundation of developing the strategic framework. And we would envision working as we outlined at the beginning of the engagement, who should be involved in those decisions, but would hope that it's a very collaborative effort, and we are socializing this with the appropriate groups throughout the process. This should not be something that we're coming and presenting to you, we're doing it with you. This is not something we do to you. This is us working very collaboratively, and at the end of the day, you guys own this. I mean, this will be a strategic plan that once we determine what the objectives and activities are, it's the responsibility of those individuals with boots on the ground to make sure that these get executed. So we need to have everybody very vested in what we've determined are the objectives of the strategic plan, have a very clear roadmap as we have listed here on how those are actually going to be executed, and tracking those.
Your vision for the process then does or does not involve elements where you need board communication and board response and board policy input?
It does.
Okay.
Absolutely.
Okay.
All along the way. And we want to make sure we've got touch points with all the appropriate groups and who is going to be responsible for helping devise this. And so typically we're subsets of different groups and understanding what is our overall goal. But when we get to the objectives and activities, those are gonna be very specific, where we're gonna be working with the right appropriate managers, directors, to make sure that those are devised appropriately, but then making sure that everybody's in agreement, that we're on alignment with the priorities of the strategic plan, and this is gonna inform the project going forward. And that's why it's so important that we're showing lots of arrows, because it is an iterative process and continually refined.
And Robert, does that, from your perspective, because I know this, all the board, I think we all have our own ideas about what level and at what point, you know, the board is, you know, is encountered in all of this. Does this become a part of our board process when we reach one of these points where there needs to be policy input or policy guidance? Is there going to be a structure in place that allows the board to do that, either within the agendized process or within some level of additional meetings? What's your vision for how that works?
Here's the advantage that I'll remind board members of, and I know y'all know this, but the advantage you have with the team you have at JPS is the reason that we were introduced to Karen Duncan is because she came here hired by the county to develop the Blue Ribbon Committee. So what a great backdrop that is to have a chief operating officer that was in the fundamental stages with the planning of everything that took place. So I think what you've got, and I appreciated the comment of refresh and all, because I don't think any board member, there's a thin line. I think what board members want and what staff want is not a new set of a bunch of new books. We have enough books and arrows to take the oxygen out of a room. What we want to do is refresh and look and match that with the strategic plan of the organization, not recreate everything, but modernize what's taken place. Because some of the preliminary work may be off because it started 11 years ago. And so the refreshing of that is really good, and then to mirror that with the strategic plan. So to Mr. Petty's point, the board involvement, I think, is going to be instrumental. The board's involvement and direction with staff is where that combination works really well. You got staff talking about the daily operations and what we see as our daily needs mixed perfectly well with a strategic overall plan of where we're headed for the next 20 years. And then you've got some skilled folks on board in addition to our team, but now you've got a chief operating officer that was an integral part of this entire process. And I think that's a huge plus.
I just want to make sure that as a part of that strategic plan is when these goals and strategies are being developed, we do have some input, at least hear the conversation. And then it will be these are our strategies that we are all saying we're all in accord with. And I'm just trying to figure out to make sure that somehow the board is.
It seems we are driving that conversation. Is that right?
You
should be. The other part of that, Dorothy, and there's one note I want to make, just this is inside baseball to us is that sit in these chairs here. DT Wynn actually pushed your mic button so you could be heard. That DT Wynn was actually pushing a button so somebody can be heard. That's just insider baseball. But the other thing that I want to mention is for you or any other group that comes before us or whatever the selection process is, very much like at Christmas time, we don't need, nor is it good for this community, to put out a publication of all the great and wonderful things that could be devised. Because we can do that. You can go home and tell your kids, we're going to Disney, and if you don't look at your bank book, you can't go to Disney. So what we don't want to do is commit this community's hopes on what's going to happen. You've got to use a degree, which I think this project will be slightly different, is you mix your strategic goals where the most help for your patients are, but you know what you can pay for and you know what you can do. So the reverse engineering portion of this is we shouldn't be listing the next 40 projects that we love. We ought to be listing what we can afford and how we can do that. That's key.
So this is perfect segue because we talk about how the process goes and having the financial modeling.
Yeah, So just a quick aside, and then oh, I'm sorry.
Before you go there,
Yes,
can I
sir.
ask you a strategic question? I've seen the market research and all that stuff. I think you guys cover very, very well from a social safety net. Can you touch a little bit about the other safety net that we have to do because as a county hospital, disaster and all that stuff? I think we don't touch that very much. And can you give me an overview of what that would look like?
Yeah,
from that
actually,
perspective?
maybe if we step back and go a couple of slides, let's talk about, I want to introduce Karen Baylor. She is our behavioral health expert. And so as we're talking about our strategies, just take a little bit of time to talk about how interrelated the devising the strategic plan and the platform for decision-making for the future, but how integral our process is going to be from the behavioral health standpoint. Karen comes to us with Navigant with a tremendous amount of experience in developing legislation and working in California. I'm going to let Karen give.
I don't think you addressed the question I'm trying to get is what if there's a disaster?
Oh, disaster
Pandemic.
planning.
I mean, we are the safety net for the county from security and all that stuff. That's what I meant, and I don't see that.
Gotcha.
I'll talk
I
about
don't see
that a little
social-
bit. Clearly, the way this is working is that we will have strategic focuses on where we need to go on a holistic basis, but we'll be looking at specific scenarios. When we do the programming and master planning, we'll be really testing that with physical criteria and physical, what will we end up with? So whenever you're talking about, are we prepared for a disaster? Are we prepared to be able to respond to that? We will be defining that within the programming and the master planning component and beginning to understand, okay, do we have the resources deployed in the right locations for us to be able to do that? So that's part of that physical side. Now, John over there is going to talk with you a little bit about financially, making sure that we understand what those elements are going to cost and what those elements mean from your ability to pay for it. And so from I guess a safety net standpoint, we'll be looking at that on the physical side of things. Does that answer your question now? Not really, okay.
I don't understand your question either. I mean, because what are you, when you talk about the safety net relative to healthcare, countywide health?
Well, I think the normal growth and all that stuff, I think and the plan cover most of that stuff. I think it's more of disaster, like, let's say, I hate to use it, like when we had Ebola, right? We're lucky we didn't get hit. The stuff here, I don't want to get to the situation like in China where they don't report because you can't get to the hospital, that's
Right.
one. Yeah. Number two, is that there's no place, there's no test kits so that you can't confirm, you don't have the lab ready to test anything. So people just die and they just burn them, literally, so you don't report them. But that's the safety net. At what level can we get to? We're not going to be 100% proof, but at least looking out 30 years, those things are very real also as well. Addressing that side of it along with this.
Okay, that helps.
And
So the safety net for social is different than the other safety net I was talking about.
So when we are doing our strategic planning and understanding volume implications, we do a lot of scenario planning. And so scenarios such as disaster, what is going to happen in a disaster situation? We do run scenarios to understand what are the implications if there were a huge influx of whatever it might be in the community. We work with communities all the time, whether they're on the coast and they have hurricanes coming or whatever it might be, that they have to be able to get themselves in position to be able to react quickly to those situations. You're not building for Easter Sunday, but however, you are making sure that you have a plan for that day. So those are the situations that we, through our scenario development, and that we're working very closely with John on the financial side to run those live as we figure out what are the scenarios that we want to be running with you to make sure that we can accommodate. And so, I'm going to speak a little bit.
Let me just try, maybe, and I think I can hit, Mr. Petty, your question, and Mr. Early theirs, and yours, Mr. Williams, from how we'll do this from a quantitative perspective. So to your question, when do we get inserted in the process? Day one, in fact, I would say we've been inserted in the process for quite a while. We had the pleasure of working with Ms. Clark, building out the cost accounting methodology. So we understand how the underlying financials at JPS were built, so we don't have that learning curve. So we're ready, and day one, the very first thing that we're going to do is begin building out this model and building the baseline, right, with all of the historical financials. So that's when we get inserted into the process. Mr. Early, to your question around, we need to make sure that we can pay for it. What we're building is not a linear, kind of deterministic financial model where at the end of the strategic plan we give this to you. That fails 100% of the time, right? The only thing you know with 100% certainty is that will be wrong. What we're going to do is build a simulation model, a financial simulation model. So while Lindsley and Greg are working on the strategic plan and the master facility plan, we're going to be continuously running those numbers through. So we'll be able to determine something like, hey, yeah, if you stage it and pace it like that, you're going to bust the bond covenants. So you need to go back to the drawing board. Hey, if you stage it and pace it like that, your operating margin is going to look great, but you're not hitting the access that you want to hit out in the community. And then, Mr. Wynn, to your question around the surge capacity is what I'll call it, disaster surge capacity. When we build that model, it's not our intent to have the only quantitative factors be financial. Those are important, obviously, and critical pieces of decision making, but we do want to work with the board as stewards of this resource and talk to you about what are the other quantitative measures you want to see, right? How can we determine access and see how that changes as we stage and pace the plan? Patient satisfaction, how can we kind of quantitatively put some numbers to what we think is going to happen from a patient satisfaction perspective? So we'll build in a lot more measures than just what we know will be incredibly important. Financial measures is what we can, within that, we can add the surge capacity, right? If we can talk about, we want to add this much access in these different communities, we can measure that, and we can also measure, we'll hit 85% of what we think is the desired surge capacity that we would need. So we can be incredibly flexible in terms of the measures that we incorporate into that model, and we will be running that model, every day if we have to, for 8 months. And then in terms of at the end of the 8 months, we want to make sure that JPS is empowered to continue to use that simulation model. So we're not building a model just for the 8 months. And I've actually done this with Ms. Clark in her prior life, where we did build a strategic financial simulation model. So I'll work with her and her team to make sure that what we build will last well beyond this. And then the last thing that I would say is I'm right down the street. My PwC is a big global firm, but I went K through 12 with Fort Worth ISD, what was then Tarrant County Junior College, University of Texas at Arlington, and TCU. So everything I'm bringing to you is right here, born in the 817, and I'll continue to be right down the street. And Ms. Clark knows she can call me, 2 years from now, and we'll mobilize and we'll revamp that model. We'll do whatever we need to do to make sure that JPS stays on the right track.
You have a lot of Texas Aggies on this board.
Ooh.
But
we're mighty. Luckily, and Miss Clark's an Aggie as well, too, so they're everywhere.
We just want you to tell us more about Ms. Clark's previous life. we have no idea she had one.
She did.
We are curious about that.
Maybe over a drink sometime. So any other questions just related to the kind of quantitative? Thank you.
I want to just reinforce that your question, your concern will be flushed out during that strategic planning component, okay? That will be one of the things that we look at in the scenario planning. We will be looking at that from a physical standpoint as to what does that mean? What will we need to have to be prepared to respond to any emergencies? And we'll be looking at, from a cost model, how are we going to pay for it? How are we going to do that? How are we going to implement that? And by the way, I'm an Aggie, but my dad played ball at TCU, so I bridged both of those things, okay? I want to make sure we don't overlook Karen. And so if we can run back to the slide, there you go. Karen is an unbelievable team member in this scenario of this team. Her behavioral health experience, we know that one of the things that you guys are very interested in, and rightly so, is building partnerships and relationships here in the community with various organizations. And in the behavioral health side, that involves basically interfacing with law enforcement, interfacing with other faith-based organizations that may end up having involvement with behavioral health. Karen has actually been there, done that. And so I think her knowledge and her ability to build these organizational structures, to be able to see how does a system like JPS work in that broader view, is really what Karen's all about. So I'll let you
Thank you very much. Pleasure to be here this morning. Good morning. I have dedicated my entire career to the behavioral health field. I am a licensed marriage and family therapist in California, and I have a PhD in clinical psychology. I won't go through my entire work history, but I think the area that most relates to this project is when I was the deputy director for the Department of Healthcare Services in the state of California. And when I started at that position, the substance use disorder benefit package was not very robust. There were only 2 modalities. We took it upon ourselves to really look at that system of care and redesign the entire service delivery system, and I led that effort. We had a very high-level stakeholder engagement process where we started with asking the question of how do our patients, our clients, access care? How do they know even where to go? How do they transition through the levels of care? And knowing that substance use disorders is a chronic condition, what happens if and when they relapse? Do they have to start over? And so we really engaged the stakeholders and developed this whole continuum of care, and that included residential treatment, short-term residential treatment care. We were the first in the nation to obtain permission and authorization from the Center of Medicare and Medicaid Services, and I have heard that 25 states have followed in our suit, so it's been highly, highly successful. A couple other highlights I just want to mention real quickly is really the engagement process, where we really want to hear from the patient experience. There is a consumer movement that has happened in California that has the mantra of nothing about us without us, and I really want to be able to honor that in this process. There are a number of strategies that can be utilized in order to obtain patient information, but there is the goal of developing a trusting relationship with them so that you get really valuable suggestions and feedback, and then having some sort of feedback loop for their recommendations. I also want to touch on the models of care to make sure that there are good transitions of care, coordination of care, and to have it be a collaborative process with a goal of integration, of looking at how you integrate mental health services with substance use disorder services, with prevention, with the primary care setting. And we've seen great successes. We've had a huge wellness and recovery movement that has happened in California that has had huge success. So I want to be able to leverage all of that past experience to this project. And just to end on a note of studies show that 1 out of 4 Americans have a substance use condition. This population dies 25 years earlier than the normal population. You have an opportune situation here where you could really dynamically change the quality of life and outcomes for those people who suffer from substance use disorders and mental health here in Tarrant County. Thank you.
I'll touch on that just briefly. We've covered most of this information, but programming, that's where we're taking a look at the physical aspects, taking a look at making sure that we're realizing that strategic plan that Lindsley and her team is putting together and aligning that with the financial strategies that John and his team are putting together. Master planning is really taking a look at defining you from a visual standpoint. How's your campus and system organized? How do they relate with each other? What's the access of each of those services? What's the actual flow within your organization? And what's your identity? What's your brand? You know, what do people recognize when they think of JPS? So the physical aspect will be testing those aspects of your project and aligning that with our financial model so that we have an implementable project.
So, good morning. Thank you so much. I'm Bill Fowkes with Cumming Corporation. We actually led the support of the Blue Ribbon Committee along with HMA. I wanted to just touch base on kind of that, now that you have the program, now that you have some of the strategic pieces put together, you really need to take what has been done in the past, to Robert Early's comment, modernize that. So get correct, updated cost estimates based on all of the strategic pieces and parts that you have. Place those in a schedule so that we can understand the escalation that has to be incorporated into that. And we do that we have 150 cost estimators across the United States. We have 30 offices. We draw all of that experience into thousands and thousands of projects to be able to bring that national expertise to bear on this project for sure. So one of the things that the other part that we're looking at for sure here is the scheduling piece. And I think that scheduling really falls into about 4 different categories, and that is the development of the schedule, that is the updating of the schedule, and then, to steal Lindsley's word, an iterative approach in terms of reporting and measuring. We really rely on kind of a last planner method that is we're measuring the success of the schedule that we put together on a daily, weekly, and monthly basis, and we make modifications on that schedule to be able to accommodate what we've actually accomplished, what we plan to do, and then what we actually accomplished. And we circle back around on a regular basis to make sure that that happens effectively and efficiently, and that we have, we have identified when we do identify the schedule drift, if you will, that we've got means and methods to be able to address those. I think what we bring to the table really is some unique scheduling and cost management tools and project control tools. What you see on the slide here is a deprofiler model that takes into account our database of information. We've pulled information from hundreds of healthcare entities across the United States and really used that to develop policies and processes to help individual projects of this size to be able to process, again, effectively and efficiently. So, thank you.
You guys only have one slide without arrows on it. And you all put a picture of Texas Children's. Do you all need a picture of JPS? We're happy to give you a picture of JPS. You have Texas Children's on it. So we got a pretty building too. We can.
Well, good morning. I'm Katrina Keys with K Strategies. I'll be leading our hub SMWBE DOBE program, basically our hub program for minority and women-owned businesses. I have more than 25 years of experience leading diversity programs for large construction programs, 17 years with K Strategies. Prior to that, I was with DFW Airport, and I started my career leading the hub program for the University of Texas at Arlington. We have a great team here with Broadus and Levis. As Monica said, we're a hub-led team. More than 50% of our partners, 9 out of 17 are hub firms, and 91% of our proposed fee will be going to hub companies. Monica is a leader in the hub community. She has served on the board of the Fort Worth Black Chamber and also the Regional Black Contractors Association, and she and I have been serving in other leadership roles and advocacy roles in the minority business community for decades. So you really have a great team here. Because of that, hub participation is important to us. We know it's important to you, JPS, and the county commissioners. We know it's important to the residents and businesses here in Tarrant County. So we have created a robust hub program for this program. And that starts off with a really extensive outreach and marketing program. We want the hub firms and minority chambers, everyone in the community to know about this program. And not just know, but understand all the projects, the schedules, when they can bid, what the procedures and policies are, how they can get engaged in the process before we start bidding work, because then it's too late. So we want people to know and understand that, and we'll do that by outreach, marketing, activities, doing networkers, so people can really understand that.
The second thing we believe is important to diversity or hub program are relationships. We want the prime vendors or prime contractors and the hub subcontractors to really get to know each other. So when it's time to bid, they have a relationship. They're not just, I'm calling a firm and putting you on my list. So we want to have activities, facilitate meetings, to really start that early in the process so we can have good bidders and good participation. We also want to make sure that we are sure that the prime bidders are using the hub firms that they said they were going to use. So we'll have an extensive contract compliance program, and then we'll have detailed reports to you of the participation of hub firms, how many dollars, what services are provided, who those hub firms are, so you know, you can let the county commissioners know, you can let people in the public know what's going on and make sure everybody sees the success of the program. Two key things we think that our team brings to the program or hub program is first a capacity building program. We want the hub firms on our team and also the hub firms in the projects really growing their capacity. We don't want them to just have work. At the end of the day, we want them to really have extensive healthcare experience and grow their capacity for work so that later on they can come back to JPS and do more work for you and really grow that area and really grow the businesses. Also with case strategies, we also bring extensive public relations and community engagement experience, and we can bring to the team is really help you promote what's going on in the program. And we can do that through a website, through newsletters, through marketing campaigns, so people and residents know that this program is moving forward, that projects are being built, that success is happening, and that also getting the community involved. So when Karen has to go out and do community engagement, we'll be there with her. So we can help her do those interviews, interview residents, interview patients, whatever we need to do, really bring that. And for large programs like this, we have also helped owners with media inquiries, media relations. If we happen to have crisis communications, we've helped in that area too. And also with major events with groundbreakings and grand openings and really helping the community know and be happy and show the success of this project. So you get all that with us. But JPS, if you choose us, the Broadus, Levis team, you're going to be choosing a hub-led team with more than 50% of our team members being hubs, with 90% of the money going to hub firms. You'll be showing the hub community that you truly want to do businesses with hubs because you chose as the first firm to really lead and manage this program is a hub firm. So thank you.
Katrina, before you go, quick question. Can you expand upon your contract compliance piece?
Yes, yes. On the contract compliance, we will be looking at all the contracts. So we'll ask the prime bidders to tell us who they're going to use and what services and when in the program. And so that way we'll meet with them at least every quarter and go through who have you used. You said you're going to use these 3 firms by this point in the schedule. Have you used them? We want to see that they're being paid. We're going to meet with the minority firms also and talk to them and make sure that they're happy, that there's no issues. Because sometimes there may be an issue and they don't want to tell the contractor they're working with, but they'll tell us. And so we can help them work through that and make sure it's a success. And also even do some site visits. So we make sure we see the hub firms out there doing work and we know they're doing that work.
Okay. And part of the capacity building process, is there a component of mentorship?
It's exactly what it is, yes. Even for our team now, we're looking at how can we mentor them in certain areas and come into agreements of how we're going to do that. And then with the hub firms out on the projects, we want to help the primes mentor them, but we also want to provide services for mentoring for those firms also.
Well, I sent my question to Steve to ask. But one other question I have is, what do you have training now on qualifying subs? In other words, we so often we talk about the diversity in the MBE and WBE, but the sub can't qualify. And so are you doing some effort now, or will you be doing some effort on that as the time goes on?
And that's part of the capacity building program where we can let the firms know what they need to do to qualify, and if they need assistance, say they need bonding, we can help give them resources of where they can get that. But also with our prime contractors, we want to do a training for them so that they know what we expect in terms of minority participation and they know how to get it. Because sometimes they don't always know what to do and they bring firms that aren't hub or they don't know how to get or find hub firms. So we want to do training before they even start bidding so they know what the expectations are here at JPS and for this program, so yes.
Quick question. For the hub, the smaller outfit, are they 1099 or W-2 employees?
The hub, well, it's just like any other company. Most of them are going to be their employees. They may subcontract out or have some subcontractors, but most of them are going to be employees, just like any other contractor firms. They should be.
Because it would be disappointing if they 1099 employee and they don't have any benefit and they got hurt on the job and all that stuff. So if we can stir the economy, I want to make sure that the economy's been benefit from it also as well.
Sure. Yeah, I think in the relationships we have here, where we're mentoring various minority firms through the program, they are individual firms themselves. They're not like a private, as separate individual contractor. These are companies that are formed that would be working with the primes, and they're not working in most cases, not a subcontractor, third tier, second tier role. They're actually up in the organizations and working day to day with each other, and each have responsibilities for that day-to-day operation. So they're not stacked below these primes. They are part and integrated into the primes so that they can really get that first line learning experience to expand their capabilities for future growth. And there really aren't, quote, contractor 1099 employees. These folks are employed by firms. The outreach that Katrina's mentioning is an outreach to those kinds of firms so that we can help them grow and grow at levels that they may not have been exposed to before. So, and that's our goal, is to really bring to mesh these firms together so that they can integrate, communicate, and the learning process is so much better. And they'll be able to handle projects later on their own because of that, much better.
I just want to kind of go back to Reverend Emerson's question too about qualifying of MWBs. Monica and I have both been involved with minority firms for so long here in this area that we know what the capacity of some of the firms are, and we know of the work they have. So they may be able to bond $3 million and say, I can bond this $3 million job at JPS, but we know they're already working on a job at 4 or 5D, and they're already working on a job at the city, and we can talk to them about how are you really going to bond this $3 million program when you're already bonding a $1 or $2 million program over there. So because of that familiarity that we have, we already know that. We don't have to put it on a form or fill it out. We have relationships with them already and can have those candid discussions with them and how they're going to be successful.
I have a question. I'm looking at your HUB and also looking at the companies that you've currently identified. The majority of them are African American. What is your Latino outreach or other minority outreach plan?
And we'll be doing outreach to all the communities, but definitely working closely with the Regional Hispanic Contractors Association, the Fort Worth Hispanic Chamber. Like I said, Monica and I have worked with those organizations extensively, but also we also can provide, if we want to provide materials in Spanish, we've done that too on projects, just to kind of show the inclusiveness of the program, but definitely going to be outreaching into the Hispanic community. And a lot of times we find there are so many more Hispanic contractors in the doing the actual construction work that we expect to have high participation of Hispanic firms. All right, thank you.
Okay, my name is Chris Briggs. I'm a Senior Vice President with the Buxton Company, which is headquartered here in Fort Worth, Texas. Not a lot of people locally know, but one of the leading global consumer analytics companies is based here in Fort Worth. We have 135 employees. This is our headquarters. Everybody works here. What we do in the realm of consumer analytics is we're helping retailers, restaurants, groceries, anybody that does a consumer service. We're helping healthcare systems and providers make location-based decisions on who their customer is. So we're identifying market opportunities. More importantly, and germane to this project, we have a public sector division that works primarily with economic development concerns to understand market opportunities related to real estate. So what we'll be doing in this project is looking to see if there are any market opportunities to develop a revenue-generating, location-based aspect to the project. big picture. So we'll be looking at trade area analysis, understanding the consumers in that trade area. We'll be understanding the workforce. We'll be understanding the visitors and the people that come and go on a regular basis throughout the area to understand if there's the potential to develop retail, restaurant, if there's the potential to develop even multifamily residential, which is something that we have experience with from a modeling market approach. We leverage household level consumer information that we update on a monthly basis. Again, we're one of the leading firms in the world at what we do, and we're right here in your backyard. Work that we've done in the past that's related to JPS very recently. In 2019, we started working with the Acclaimed Physicians Group, and one of the things that we did was we were looking at the market expansion potential within Tarrant County for urgent care, for behavioral health, and for the patient-centered medical homes as well. So that's work that we did, we concluded, and continue to support. But we do have a line of sight into affiliates of your organization and what the mission is. More importantly, we are based here, even though we have global knowledge and nationwide knowledge in the areas that I'm talking about that we're bringing to the table. And then for anybody that's an Aggie, personally, I helped, while I did not go to Texas A&M, I established a consumer analytics practical application course in the May School of Business, and I'm a regular speaker there. And for anybody here that's a Horned Frog, I've been an adjunct instructor in the May School of Business as well, talking about consumer analytics and what we bring to the table. So I will bring our firm's expertise, and not just me, but a team of people that will work on this project to help understand if there's a market opportunity for this that can generate revenue for you and support your mission in additional ways.
You all have totally misplayed the A&M card.
I don't think so. I think it's right on point.
Yeah. Oh, yeah, you may have won 3 votes, but there's 11. Just saying, you understand analytics.
And if anybody's at UNT, I've got you covered there. That's fine. Wharton School of Business, if anybody's from there, I've got you covered there too.
Go with there, where he pitch you out, we got the Aggies up there, right here.
That's good. All right, thank you.
Very briefly, I want to make you aware of a unique capability of Broadus. Delivery systems, alternative delivery systems is something that we've been involved with for a long, long time. House Bill 1048, which allowed P3 partnerships for governmental entities in the state of Texas, was a House bill that was actually put together with Broadus sitting at the table. We were the only program management firm that sat at the table in the writing of that bill. We were an advocate for that, and that's been a very successful alternative delivery for many projects throughout the state of Texas. Additionally, we have the ability to bring turnkey financing to projects. Sort of unusual, but we do P3, we do design build, and we can bring turnkey financing. So I just simply wanted to make you aware of that. Our overall mission as a company is to advocate for owners to make the building process dramatically improved, and that's part of that process. So I simply wanted to touch on that.
I want one question on P3.
Yes.
I think there's been a lot of assumptions made about the way this program will ultimately be deployed. And honestly, P3 has been a parenthetic sort of sidebar. My first question today related to how we're ultimately going to pay for this. And one of the things that we've spent a great deal of time looking at is alternative revenue streams over the past 5 years, knowing that this is going to be crucial to us. Is it you all's impression that this is already designated as a GC or CM at risk type of project, or is it really thinking through that to see what P3 opportunities are out there so that we don't get tied to only a GC or a CM at risk ideology?
Right. There's not a, go ahead.
3P is
Public-private partnership.
But you mentioned 2 others.
Well, the methodology that JPS typically uses when we build big buildings is one of 2. It's a general contractor, it's a CM at risk. CM at risk most, normally, especially on the larger projects, which are both great plans, but neither one of them really integrate P3, because P3 brings in a third-party capital funding source that JPS then looks at an operational relationship with over a time that could avoid some of the capital cost to us and offload some of the operating cost to a different firm. And in a project of this size, there's a lot of opportunities for that. And I don't think it's been given a whole lot of discussion, but I'd like to know y'all's perspective on its appropriateness here.
You bet. There is no one-size-fits-all, first of all. Your main line of business of providing care, providing health care, is probably one that would more want to go the CM at risk. The P3 is really applicable if, for example, you wanted somebody else to operate all of your parking structures, that they managed all those. That's not your main line of business. You're not in business to operate parking structures. So P3 might be a really good model for that. Central plant is a very popular thing right now, and that somebody else can come in, they can maintain that equipment, they can end up making sure that it's always at the latest and leading edge of technology because it's their advantage to do that. If it's more energy efficient, their returns are better. So those are two specific ones that we're looking at a central utility plant right now on a project in New Mexico that would be an outside third-party entity, and they're actually saying, we'll come in and we'll pay for all the deferred maintenance of all of what you got today, we'll build new plants, and we're going to give you back X number of dollars just in capital money today that you can spend on whatever you want to. That's the way that they structure their deals. So that's what makes P3 pretty attractive in some project types.
We just want to know that you're going to be looking at it.
Absolutely.
And that those alternatives are going to be brought to us as you arrive at them.
Absolutely. That is part of when we look at projects and look at the implementation of projects that we would certainly be focusing on.
Thank you.
Trent, I have a kind of logistics question. So, we were told 45 minutes.
Yeah, we kind of blew that. We kind of knew we would.
We love the dialogue. I just want to make sure that we're overall.
We don't want to stop you from your presentation.
Okay.
So
No, I just
we'll,
want to make sure that
we will ultimately get back on schedule, but that, we only have two, so we won't be here until midnight.
Great, thank you. So what we're going to talk about now is we've finished our 8-9-month assignment, and we're going to talk about the next phase that's outlined in the RFP, which is moving into the implementation of the projects, where we're going to start with hiring architects, hiring contractors, and really moving forward with construction. What I want to focus on here real quickly is we talked about the bottom of our 9-month, 8-month schedule was our PIP plan. And this is where we've developed the plan. The plan's been developed in the first 8 months. We ask a lot of questions, we get a lot of detail, so that as soon as we're ready to go, we've got our processes down, we've thought about what is our cost model, where is our schedule, so that we're not trying to figure that out on the fly, because what's going to happen is at the end of that 9 months when we get started, we have a lot of projects. There's a lot of projects outlined, and we're going to go through that, but we need to make sure that we have our PIP plan in place. Not going to go into a lot of detail on it, but if you did get our response, the outline of that's about 50 pages. That's just the outline that we're going to use in our 16 workshops that we bring in our industry leaders within Broadus that drive that. So that's what this is illustrating. So when we move into that phase, I want to make it clear, like we talked about before, that our strategic planning group is still involved. Okay, but just to make this slide read a little bit better, we took that line out, but to make it clear, our strategic planning team is still involved. We see that the refresh or touchbacks between that planning team is still in play. We have our IPMO office. We're managing this project from day one till 10, 11 years from now when we finish. So that's what's highlighted. So in that first long bar is our program and project managers, and we've aligned the projects that have been outlined in the RFP and in your bond program with our project managers that align very well, have a lot of experience in doing that particular project. Right underneath that, we have our field team, and those are inspectors. Those are our employees that work to make sure that the work that's being done out on the projects are being done accurately, being done correctly. Underneath that, we have our third-party reviews, and those are our experts that will be overlooking documents, making sure that when the architect and engineers are working through their documentation, we have another set of eyes. We look at constructability. We make sure that it's going to meet the program, the outline program, and also meet the budget. expert in Lawson, which is your accounting package that you use for all your materials management purchasing. We're going to generate thousands of POs, and so we'll have someone on our team that can work closely with your accounts payables department to make sure that those are being processed, because one of the worst things that can happen in construction is we get behind. And so especially with the fact that we've got some smaller minority firms, they can't wait 60 days. They can't wait that long to get paid. So it's really important that we stay on top of that schedule. We've got, at Broadus, we've got best practices. What this illustrates is we've got 14 that we focus on. The top line, the top bar, and the lighter color, that's our pre-planning kickoffs and partnering and scheduling. And the lower part is where we actually are in the design and construction. We've got, like I said, we've got best practices actually around each one of these, where we focus on, constructability review, cost control, change management, and so that's what that's illustrated on that second bar. And here's where we've developed our PIP in the first 8 months, and we're implementing that. That's what we're showing here. We are going to use that as a roadmap. It's a tool that we will use throughout. It's flexible, but yet we've got a lot of these really important big decision questions answered up front, and that we're going to use that throughout the entire project that establishes our process and make sure that we stay on track. I do want to spend a couple minutes on this. This is really, really important. This is our schedule. And I'm going to step back here so I can show you. So the schedule that you see, and if you have your placemat, on the back of the placemat, you're going to see the schedule. What you see here in color, the colored bars, this was the schedule that was given to us in the RFP. So this outlines the projects that are in the bond program, and this outlines the schedule, that the milestone schedule that we should look at and go by. So that's what you see here. When you see a red arrow, those are things that we looked at and ideas that can improve the schedule. So right now, we've got a schedule that extends out to 2032. So we're going to show you 6 really quick ways that we think that we can improve the schedule. First of all, right here in the beginning, hiring our geotech, survey, environmental study, get that done early in the project. I mean, let's start that now, because those are things that take time. We need those tools. So we'll start that early. That's one. Number 2, align the medical home 3 and 4. You've aligned already medical home 1 and 2. What we're saying is there's a great way to bundle those. If we can move the medical home 4 in alignment with medical home 3 and then shift those up in the schedule. So we gain some opportunity to bring those other 2, 3 and 4 on early. The other thing that's really important too is we talked about delivery methods. Trent, you were asking that question. Here's some ways that we think we could also improve the schedule by our contracting method. So if we want to do design build, if we want to do fast tracking, early release packages, those are things that have to be well coordinated. But when we do that, what we see here in the colored bar is really just that traditional design bid build, very linear. What we can do is condense the schedule, because we can start our design, be working on our design, get our foundation package, get that done while we're starting construction. So that's another method that we can use to shorten the schedule. A couple of things too, we see this gray area right here in the middle of 2025 and into 2026. There's not much construction at this campus going on during that time. So it's about 14 months. We got a gap in the schedule. So what we're saying is we can move Morphy Street garage. We can also move the new tower construction. We can move that up in the schedule, because right here we've got just a bit of a gap where we've got a lot of construction going on here and more back here, but we want to pull that forward. A couple of things, the benefits of that is escalation. Escalation is about 5 to 6% right now. So if we can move that up, then we've not only gained time, but we save money. The other thing it does, it means you won't be paying consultants like us any longer than you have to, because we'll be off your campus sooner, and that'll reduce that cost as well.
Oh, we don't want to reduce our costs. Go ahead.
Lastly, so really important project is the PCC project. Okay, so when the PCC project finishes, we have a lot of specialties that are moving into the PCC. Second floor of this building, they're moving. And there's going to be other departments in 1400 Main, 1350 Main. Those are specialties that are going to be moving into that PCC, so you got vacated space. So let's start that backfill and start that renovation work early. When we get this done, let's have a plan for what we're going to do on our second floor here. So by doing that, we can move our backfill up and reduce the schedule. So instead of waiting until the new tower is almost finished, we're going to start that early. So we gain time there. Ultimately, if we take and look at all of those, this red line here, this arrow represents that we think that we can at least move the schedule probably 2 years earlier. So that's, again, savings. Savings of time, saves money. Any questions on the schedule?
John, Derek, some of this will be driven, some of the compressing of it, though, won't it be impacted by, like, John's financial numbers?
Yes.
How we can pay for the operation?
Exactly, and that'll all be worked in through the model to make sure that we're able to do that. And then we'll see the benefit. So we say we're gonna move this up, and we have a savings, but we definitely wanna make sure that we're able to pay for what we have.
I think one of the things to kind of augment that is that as these schedules are developed, and we look at the different delivery methods, we're going to have Price Waterhouse doing a programmatic cash flow analysis across the whole program. Because we're dealing with bond sales, we're dealing with those kinds of things, and we want to maximize the benefit there. So we've got to appropriately match the cash flows across the program, and we will be doing that.
Have you already looked at some cost analysis with moving this around? For the schedules?
Pretty high level, but we have looked at that. We've looked at, just looking at escalation savings. That alone can be, millions. The savings, like I said, of our time, when we were building up our fee structure, having that gap in there just pushes that out. So that's probably, at least probably $1 million in savings right there alone.
If I can, Derek, a couple of other things that I wanted to mention was that, one of the things that we look at when we combine some of those things together is really taking advantage of some bid savings. So we were doing bidding, and we were having general contractors have a shorter duration, so you were paying less in general conditions as well, in addition to less consulting. I think the other thing that is more of a qualitative thing is really the impacts that that the construction can have on the operation, and the years and years of being able to, of having construction on this site are something that you all need to think about in terms of limiting that, so that we can get this done, get through, get in the new buildings, and get the construction out of here, so you can not have that as an impediment to operations.
Yeah, I think one more thing on the program phase of this, we've looked at, and we've mentioned it in our written response, the opportunities for savings if we will standardize materials across multiple projects. So there might be an idea that we could use what I would call a master program architect who would standardize architectural finishes, hardware on the models that and on your present specifications. But that way we don't have multiple architects designing multiple different finishes, and the same thing with the engineering side as well. So this would help us in minimizing cost. It will help you in your inventory control in an operating scenario where you don't have to maintain so many different parts. And so that's part of what we'll also be doing if we go that route, with maybe more of a campus-wide architect to oversee that. And they can feed the other architects these standard specifications.
One of the things we wanted to touch upon that we feel like is really significant about this team is the depth of experience and expertise that's embedded in the team. We've selected 3 recent projects. the UT Health Behavioral Health Hospital in Houston, approximately 300 beds being added to the Texas Medical Center. Broadus actually did the planning and programming on that facility. We also are doing the project management, program management on that facility. The lessons learned from what's occurred with that is something that will absolutely be able to be applied directly to the work here at JPS. Memorial Hermann was about a $750 million expansion, new hospital tower, and pretty much a full-service hospital component developed there in Houston as well. The knowledge that's coming off of that facility has actually already had their main facility grand opening, but there are going to be some other staged openings that are going to continue for different components of that. But the lessons learned that deal with what do we learn about the site, what do we learn about tight constraints, what do we learn about being aware of potential pitfalls that might hit a project of that magnitude. University of New Mexico, I mentioned it earlier. That's a project that is actually adding a whole new hospital tower to the University of New Mexico. In that project, we're tearing down parking structures, we're building new parking structures, we're having to deal with the logistics of same things you guys are being faced with. So being able to share that information. We're learning that precursor projects on each and every one of those were mandatory. We had to do some things to clear out zones that we were going to be able to have available for us to develop the projects. So all of the knowledge that comes from doing all of those projects will be leveraged from the Broadus team into your facility. We are able to literally pull in a resource here or there and be able to bring them into the project to be able to help provide that input. This is just a real quick snapshot of the Texas Medical Center. Those blue bubbles are actually projects that Broadus did all the program management on. And we're very proud of that. So when you look at the Texas Medical Center, we've done some significant work there. The TMC in general, if you look at just the sheer volume of building space there, it ranks as the number 8 largest downtown in America. So there's a lot of square footage there that is represented. And we're proud to have been a part of that. That knowledge and expertise will be applied to your project.
Just a few more lessons learned. I just came from, as I mentioned, a facility where it was a large bond program facility, and then I had the opportunity also to move over in to operate that building after it was built. Boy, did I get a lesson learned there. But it's important to understand what we turn over and how it has to be operated. And there's some things about it that I think are some things that we may not think about, but things like facility operations and how we do move management. If we're moving out of one facility into another, the thought processes and the teamwork that has to go on every department in a hospital will be involved in moving patients into a new facility. So there's a planning area there that we will handle in this program. The issue with mechanical equipment, medical equipment, logistics, how to procure those volumes of equipment. Can we reuse other existing pieces of equipment? What kind of certification and recertification would we have to do? Those things. And then last, when we leave a building, even before we maybe demo it or reuse it, we have to decommission it and get it ready for the new use. And that decommissioning process takes time, takes money, but it is a very valuable step to get that building back into operation. We bring that expertise.
So quickly, I want to just talk about just what we see as the overall, not just managing construction, but we see this as a great opportunity to help transform healthcare delivery in Tarrant County. That's exciting, and we want to be a part of that. This just illustrates a few things of thinking. We talk a lot about the main campus, but there's critical things going on out in the community, and we want to make sure that, we talk about new locations, but we also need to be looking at Stop 6, Old Pits. We need to look at all of those facilities because is the IT infrastructure so that the microphones work there. All of those kind of things are not forgotten, but they're really still very important part of the overall so that our patients have access. We talked about some partnership opportunities, real estate development, and other opportunities for revenue streams.
So lastly, I just wanted to kind of summarize a few things. I love the JPS culture here. You hear a lot about it. So much so that I decided to volunteer, and I love volunteering here. I work down the helping patients down in the clinic, and you really get a good feel. You really get a good feel about your staff, about the patients, and what this culture is all about. It's very unique, and it's a place that people want to come to, and we want to know that everybody in Tarrant County should feel very good about coming to JPS. What I have noticed, and what you guys know, is you've been very resourceful with these facilities. Being on the second floor and wheeling a patient down the hall and leaving them in the hall, we know that's not ideal. The second floor, small exam rooms, when a patient comes in and they need to see a neurologist or cardiology, that's over 1,400. So those are things that we're excited about, what these projects are going to be able to deliver to your staff and to your patients. We've needed them a long, long time. I was here 14, 15 years ago. We talked about some of these projects. So we know how important they are. We appreciate the fact that you guys want to take the time to do our planning up front. That's hard because I know we all want to jump in and get these projects done so that our patients and your staff can start utilizing them. And through that, we're going to take on the attitude of ownership. We're going to own this process. We're going to be here. We're going to seek joy in the process when we do that. And what we mean by that is the joy that our patients and our staff are going to have when these projects get finished. And lastly, we're not going to be jerks about it. Okay? So what that means is we're not consultants that come in and shove a bunch of stuff at you and say, well, we're the experts. We know this national thing, and we're not going to do that. Like I said, the IPMO is going to be an extension of JPS. It's like another department, and I'm excited about taking on the culture that you guys have. I would love to have the opportunity to spend about 10 years here working with them. Great. With that, we're finished. Thank you.
I just want to say, great presentation, but I would hope, though, I understand that we individuals who sit around this table are charged with the ultimate decision on where we go after we even select the firm for that. But one thing I just would hope, though, we not miss that the key part for me is that the staff is involved in this process. And I would hope the board would come to grips with that also. We sit around this table, but the experts out there in that audience. And I would hope that we would listen to them as we move forward.
And that's, I agree 100%. The concern is it's going to take a lot of time. And that's one of the reasons why we said, let's put our office here so that we're taking good use of their time, but it will be a lot of time. Yeah. Especially in that first 8 months to make sure that we get the feedback. And that's what the big arrows were all kind of pointing to was the staff involvement. It's a huge deal.
We appreciate y'all's time.
I've got one more question. Yeah, thanks, Trent. I understand construction, and I understand that you guys have put together an extensive, hell of a dream team. I'll say that. How does this page move in an environment where healthcare is changing faster than construction? And how does this, and I'll call it just a mini bureaucracy, have the foresight to see the changes that it's going to be totally different 5 years from now? I mean, I know we're doing the 8 months planning now, and we'll do some stuff going on, but this organization and this organization has to continually evolve and change. And I want to make sure that because this is such a large, robust team, how it's going to be able to move quickly.
Great observation, and we are. And like we said, we've got a quick start team. We're ready to start. We've got the commitment from broadest leadership. So
so that when we do start, that we've established all of our protocol, all of that up front, and it does need to be flexible. Just like the facilities need to be flexible, we need to have some flex in there as well. We do have a deep team. We have a lot of resources that can be flexible. And we just have to be able to, adapt. And there's going to be a lot. You can imagine this campus with probably 800 construction workers, okay? That's probably what we're talking about during the heavy lifting. And you need someone with the experience like Broadus that can manage those kinds of projects, to think about, we don't want to impact patients, we don't want to impact staff, but you think about that, the materials, all those things coming into this campus, you need the knowledge, and we have that knowledge, but we also know we need to be flexible.
Let me go ahead and touch on the forward thinking and the future response to future technology, future access methods. You know, everybody uses this, and that's going to be how a lot of people interface your system in another several years. Being able to understand that, being able to look at what does that mean from your facilities, what happens to your facility. So part of that begins with the strategic scenarios that Navigant will be putting together. Without a doubt, anything that we do, we know that things are going to change. And so first and foremost, everything's got to be able to respond to change. So it's got to be a flexible framework that allows us to be able to ebb and flow as things that we don't even know about today might happen. One of the things that you guys are enormously blessed with is you are not a landlocked campus. You've got a lot of land here. And so making sure that whenever we look at facility solutions, that we're leaving open areas that can grow and can respond, so that we don't end up building something that has everything so tight and so connected that we don't have any ability to expand. We build ourselves into a landlocked position. So I think that's going to be critical as we put together the physical solutions, but also the strategic solutions as we look forward.
And just want to add, Mr. Fisher, so we're actually fortunate that we have PwC's Global Health Research Institute leader here in Fort Worth as well, Benjamin Isker, who has a history as a legislative aide at the state as well. So we plugged him into our process and into our modeling process, and asked him to use our regulatory desk to help push on the assumptions that we're building through that model. So, you know, nobody knows. I mean, the reality is nobody knows where this goes, especially when we're looking at a 10-year time frame. But we want to make as informed of guesses as we can. And so that's just one additional thing that we're going to do to pressure test on.
Thank you, Trent.
Thank you all.
Thank you.
Thanks.
Thank you very much. Appreciate it very much. Thank you. Good to see you. Good to see you. Thank you. Thanks so much.
Very important question. Very nice.
Thank y'all. Thank y'all very much.
going to begin again at 10:16 hours. Trent, you want to say anything?
Thank you, Mr. Chairman. Welcome, folks. We're glad you're here today. Just a little bit about our process. We have asked that each of the two firms being interviewed give us a broad thumbnail sketch of your process and be able to summarize the multiple pages that the committee has reviewed. We appreciate each of you being here. We ask for your patience with us and indulgence because our board is very involved in this process, and we will be asking questions. So as we ask those questions, don't think we're interrupting you. We just want to understand that because of the complexity and the size of this, if we don't ask when we come across it, we may lose the opportunity to ask. So we want you to have plenty of time to make your presentation. We understand you have one person that's in route. If you could go ahead and start and insert them when they get here, that way in the board's time frame, I think that works great. But welcome. We're glad you're here. And so, Mr. Chairman, this is the JLL firm.
All right. Welcome.
Thank you. What an exciting day for JPS, Tarrant County, and us for being here. We really do appreciate that. My name is Stephen Donnelly. I am with JLL. I am a Senior Vice President of Healthcare Platform Lead for the South Central region, which includes everywhere from San Antonio to Kansas City. I've done 29 years of healthcare project delivery, 20 of those years as an owner and also as an owner's rep. As a taxpayer in Tarrant County, I'm very excited to see this program come to fruition. I will be responsible for making sure that we have the tools and the resources and the team for the entirety of this program, and I'll also be your single source for accountability for that team. As we were preparing for this presentation today and the challenge that this program brings, we were trying to figure out who had the bigger challenge, us presenting today or you guys trying to figure out who you're going to partner with for the next decade. We know that relationship is going to be based on trust, and we want to prove to you today that you can have trust in JLL and the team that we've formulated, and we are honored to be here today, and thank you for this opportunity. On the board, you can see the content that we're going to cover today. I'd like to just jump right into the approach that we started with JPS. One of the things, before we even started talking about the program or the projects, we wanted to look at what is JPS's mission. We know that you want to transform healthcare delivery to its community. JLL and JPS have very different business models. We are here for providing healthcare solutions. You guys are here for providing care to a community. Where do those mission statements and values lie? You can see the JPS values versus the JLL values. There are many similarities between the two. But we know at the end of the day that this program is not about the buildings. It's going to be about the journey that you get there to get those buildings to take care of people. You're going to be thinking about population health. You're going to be thinking about access to care. You're going to be thinking about patient experience. And we have assimilated a team that will take care of all of your concerns. And when we were putting this team together, we had 4 criteria in mind. One is the existing relationships that JLL and JPS has. We have 17 members as a part of our integrated project team that have either done work at JPS or are currently doing work for you. Second, we wanted expertise. We know that you want the best and the brightest that have delivered healthcare projects, and we have put those members on our team. Third, we wanted to have local presence. We want to keep as many dollars in Tarrant County as we can. And fourth, diversity. We wanted to make sure that everybody has an opportunity to participate on this enormous program. We believe that we have put a team together that is second to none. Our team is going to listen, and we're going to provide solutions that can help you make decisions and keep JPS sustainable. Now I'm going to let the individuals introduce themselves.
Good morning, I'm Mark Harrison. I'll be your IPMO lead on this program. I have 27 years' experience in the project management industry, the last 17 being in healthcare and life sciences. I recently completed a capital improvement program for Houston Methodist down in Houston, and in that time frame, we delivered $2.1 billion worth of construction over a 14-year period. I had a staff of 29 when we peaked out. We were working on 7 different campuses. The picture at the very top, that's the Walter Tower. It was the last piece to go. It was 700,957,000 square feet, and it connected to existing buildings on 6 different levels, including a sky bridge at the 9th and 10th level. So feel this is right up my alley.
Hi, my name's Dana Pitzenberger. I think I've seen many of you over the last 9 years. I've been a registered nurse for 30 years. 17 of those years, I ran maternal child health and pediatrics in a community-based hospital. I learned operations, compliance, and reimbursement. I left the hospital and I worked 9 years in the community in a HME corporation. I ran a corporation, a national corporation. So we service chronic care patients with congestive heart failure, wound care, and diabetes. I also owned and operated a home care company in the state of Texas in the middle of nowhere. We had 6 locations to serve the Medicare, Medicaid, and indigent population. During that time, I learned how to write research grants for transportation for access of care. I bring a lot of years and a lot of mileage to the table. In 2008, I joined an architect firm. In my very first meeting, my job was to do clinical operational planning and efficiency and flow when it came to hospital design. And my very first meeting was, I don't know if she's here, but was with Angie Morgan and Casey Tang. And I have been chasing this project and learning about this project since 2008. It means the world to me that you guys have us in this room. This is kind of where I grew up, this kind of patient population. I came from Iowa. It was rural health America. A lot to offer. I keep up on reimbursement and the future of healthcare, and we have assembled a team that'll hopefully future-proof your bond program. We want to make the right decisions for you, give you information so you select building typology, the right size, and at the right time, and look at the future of how your doctors are going to deliver care. The buildings have to be ready to be flexible enough to deliver that model. So I'm here to help all of our team members with all that knowledge.
Thanks, Dana. Well, I'm Bob Hunt, and I've been brought sort of as a specialist on this team, and I'm managing director at JLL, and I run our National Public Practice Group for state and local government and higher education. And one of the things that resides within our group is our public-private partnership specialty practice. And we're currently, over the last few years, coming on $7 billion of alternative infrastructure delivery through public-private partnerships. It runs the gamut from veterinary hospitals to a $1 billion campus expansion to housing to wastewater treatment plants to energy plants and all the gamuts around there. And my role on the team is to provide expertise as it relates to potential alternative delivery structures that may be appropriate on various projects as they come up, and it's an honor to be here and excited to be on this team. Thank you.
All right.
So we chose Jason Williamson and the Dunaway team for our parking and traffic impact studies. We know they've worked on your campus for quite a while and have a good reputation here, doing good work for you. And so they're also on the team.
Let me introduce also, this is the group we mentioned that's en route and running into some delays, but their role in this, they are the strategic planning lead for this project, and they have a lot of experience. I'm familiar with their work. I've been talking with Scott and Kristen a lot lately. A couple of things that I think are relevant in their background. Number one is Geisinger, you can see on their list there. So for those who know Geisinger, right, and they did master planning for them, you know, physician-led organization, very patient-centric, dealing with a huge population in the state of Pennsylvania. If anybody is positioned in the health system world for population health, it's them. That's their driving mantra, and they face a lot of challenges with that. And so when Halsa does get here, they may speak to that. but they understand that model very well. The other one is, this is important, you see University Medical Center El Paso on that one. They have a very long, they're really their advisor of choice on that project. They've been working with them for 10 years and have done all of their planning, strategic planning, master planning, ambulatory network planning, and they've done a great job of sort of helping them really maximize their financial performance as well, starting with the strategic planning and leading into that. So, me, I am Sam Sears. I am principal and founder with Percival Health Advisors. I was in a hospital for 5 years working at Brigham Women's Hospital in Boston in a clinical research setting. I've been doing consulting for about 20 years now. Also part of my team is Mark Coughlin. He has a background in accounting at Deloitte. I also have an MBA. The reason I mention those two things is because my role in this project is financial planning lead. So, and I am going to be supporting HALSA in the strategic planning as well. And both of us are big believers in the integration of strategic and financial planning. So we're going to be working very closely on that. You can see on here, I've got a few pictures of places I've worked. Some of you may be familiar with me from JPS. Back in 2017, I did some of the ambulatory network planning. I'm going to speak to that a little bit. I was also at the end of that project asked to sit in on the panel during the bond hearing. And during that hearing, I spoke up a couple of times in support of the project, and so I was very excited after that the bond was approved. So I'm excited to be here. Two other ones quickly, sorry on that, was Harris County. I did some operational planning with them. I wanted to sort of illustrate a couple of other county public district hospitals. Harris County, I did some operational planning that also dealt with their prison population. Cuuck Delta, I worked on a $550 million bond project, so I did master planning for them. One more, just finally, that's not on this list, but I think is relevant. I did this last year. I helped Stride, which is, you may not be familiar with them, but they're the largest network of FQHCs in the Denver market, so they serve a lot of the same types of patients, very community-oriented. So I help them with their ambulatory network and their modeling, and that's very important in this process, because if you think about the patients you served and creating access, a lot of people always think about the hospital campus. You know, they were at the forefront of primary care and getting that out. So I think that's something we're going to be looking at closely in this project. Thank you.
Hello, my name is Michael Smith. I'm with E4H Architecture. I'm one of the partners here in the Fort Worth office. I will be leading the master planning team. The team is composed of Corrigan Architecture, also NWA Architects, and Behavioral Health Facility Consulting. Ourselves, Corrigan, and I'll say Behavioral Health Facility Consulting have all worked at JPS or are currently working at JPS. E4H is the largest dedicated healthcare firm in the nation, and we have master plan projects, you know, anywhere from the small as they are up to about 8 million square feet. So thank you for your time.
Great. Morning. My name's Ken Whittle. I'm with Burns & McDonnell here in our Fort Worth office. We'll be providing utility master planning services on the initial phase of the project and then construction management support during the implementation phase later on. I'm a 28-year resident of Fort Worth. Been working in the design and construction arena here in this community since '92. Most of that inside of Loop 820, and most of that is in the healthcare arena in one form or another. I'll be working closely with my associate, John Schwartz, who leads our on-site energy and power group that specializes in campus utilities for higher ed, healthcare, and also district energy systems. We'll be supported by Adam Amati, who's done a lot of work here on your campus and provide us with some valuable insight as we begin to explore the existing conditions here on your campus. Looking forward to it. Thank you for having us.
Good morning. Hi, I'm Mary Ann Durr. I'm the president and founder of Synergy. We are also healthcare advisors with a focus basically on providing the support from the clinical as well as the operational and planning, design, and construction. I've been a registered nurse for over 25 years. I served for 8 years active duty in Desert Shield and Desert Storm, during which time I captured a lot of the best practices and how to process optimize. We will be incorporating many of those techniques, skills, tools, and developing the process optimization plan. We have worked in hospitals around the globe, some of which are featured here in pictures, some recent ones here in Texas, as well as currently with University of Mississippi and the New Children's Hospital. Patrick Casey is part of our team as well. Patrick is a subject matter expert in this field, an architect, registered architect, as well as has been an executive in hospital organizations around the globe as well. We're happy to here to serve you in the process optimization planning.
Thank you.
Good morning.
Good morning.
My name is Claude Udrich. I'm a local fella here. We have an office just down the street. And what my responsibility will be is to manage this project, to help the team and to help you manage this project's budget. That is critical. Also, we have a lot of expertise when it comes to managing and working with large projects. We were part of the project controls team for Parkland Hospital. In fact, Patrick Casey was the person that I worked for during that process. Also, too, we have a lot of expertise when it comes to large government projects. One of the projects that we were on from 2006 to 2015 was the Fort Bliss project. That was a $4.6 billion project. And so we understand how to communicate with multiple teams, how to communicate with multiple stakeholders, how to bring all that together. The critical part of managing this budget, especially because it's going to be over a decade, is to make sure that we're constantly managing the market, right? We're looking for anything that can affect the cost of your project. We also need to be very diligent that when the project runs over budget, that we get the team together to start looking at value engineering processes. Now, not just basically pulling things out of the project like a contractor would do, but looking at how we can change or reduce costs, but still maintain the value of the project. So I'm here to look after your money for the next decade. Thank you.
I'm here to represent Tanya VC. We've asked Tanya to join our team because of her many, many years working in the community, understanding the community, understanding how you think and how you make decisions. Also, she'll work closely with our communications team in bridging information over to the community as needed. She'll work closely with your communication team if that's you so desire that. She's also overseeing our hub coordination planning. This young lady right here, she's got 25 years of experience in the industry, and she's going to make sure that we stick to our hub plan. And we have dedicated 31% of our operations or our project management workload to 4 different hub organizations. In fact, we have 6 on our team, and we're glad that they're here from Fort Worth and Dallas. They bring a wealth of information when it comes to selecting the right teams and having those relationships so they will participate in your projects over the years. The market is tight. I think we talked about this at length. We have to manage the market clearly, stay ahead of it. We picked these guys because they are Fort Worth folks and they have these strong relationships that we can bring to the table, so we deliver that 31% properly.
Just 2 other things I want to say about our team is we were talking with each other, and why we selected the team is that we are all familiar with each other. At some point, some team member has had a touch point with another team member on our projects, and that's the reason why we wanted to work with them. The other thing that I'll say is that so our relationships together are strong and we know each other. The point I want to make is how we get to know you. I wanted to let you know that we have spent, this lady right here has spent more than 2 years. I don't know if she's missed a board meeting, but if she has, it's been very few. She's attended finance meetings. We have walked your campus. We have driven around your campus. We have read all of the reports and familiarized ourselves with all the reports that have been produced to date. And I just wanted to let you know that we're here and we want to get to know you even better so that we can help you in the future. So in regards to all that, how are we going to herd all these cats? We've brought 10 people here today. Just for the initial project services, we're going to have at least probably 53 people touch this phase of the project.
I don't want to violate HIPAA, but if all of you became patients at JPS, our payer mix would change by 35%. Just saying.
You challenged us, you said bring us 1% more revenue.
Yeah, there you go.
That's why
There you go. There you go. I'm just saying.
And those 53 people are just on our team, not including all of you, all the stakeholders, Number one, and Mary's going to talk about this, Mary Ann's going to talk about this a little bit as we talk through process optimization, but we will put project governance program in place. We're going to have project charters. We're going to have schedules that we put in place. We're going to have communication plans. We're going to have rules of engagement on this project. So lean in itself is part of the JLL culture. And there's probably a lot of terms on here that you may have seen but don't know. We have experts on our team, throughout our team, that have Six Sigma experience. We have total quality management experience. Ken and I go way back with lean project delivery back in our Lindbeck days. So we have tools that we're going to use to manage this project. Why do we want to use these tools? It's to eliminate waste. We know that we want to be effective for your team and make sure that our project delivery methods do not bring in extra costs or time to the schedule. Another tool that we're going to use is, I would recommend on a project of this size, and don't get me wrong, once you get into the second phase of actually bringing projects to life, the 53 team member is even going to grow at that point, depending on what that delivery method's going to be. A big room approach, having your team co-located and being in one room is going to bring a lot of solidarity to the team. It's going to allow for real-time updates on planning, budgets, schedules, things that we can relay to you so that you can make educated decisions down the road. Partially falling off the wall over here, we took the liberty of putting a full plan together for just the first 9 months. And the activities that we put on there are only the activities of somebody delivering something to someone else. And it's very important when you're going through the last planner system and the full planning session is commitments to others. You have to be able to get down to the granular level with people, whether it be a manufacturer, whether it be someone that's doing drawings, whatever it is that someone needs to deliver, you need to be able to commit to that date. And so this isn't just a contractor going and putting a construction schedule together or us putting a program schedule together. It's involving everybody, your stakeholders and ours, to make sure that the deliveries that we make are given on the dates that we say that they are, so that the next person can start what needs to be done after that.
It's an accountability.
It's an accountability that will ensure that we are staying on time, staying on schedule, staying on budget.
So to that, our team will staff the Integrated Project Management Office, which starts at day one and goes through the closeout of the entire program, right? We will manage the initial program phase, where we're doing the planning to get us to the point where we can start construction. And then the continuing program management, after the first phase is over, we'll manage that process, traditional design, construction elements as we go through the 12 years after the first phase is complete. So that's, you guys have that
On your
placemat. That's our team. That's all of us there. Now, the majority of that team is focused on the first 9 months. After those first 9 months, significant number drops off, and then we get down to just our project management people as we get into the design and construction of each of the projects in the program.
I'm sorry to
Sure.
interrupt. May I ask? Sure. You talked about the big room.
Yes.
Do you anticipate co-locating that here on campus?
If there was room, I think we'd love to do that.
That's an ideal arrangement, and we've done that in the past before with great success, for a period of time. When we actually enter into the construction phase, though, it's more important for them to be able to focus on their individual needs and kind of disperse where that is.
We want to find a space that if it's not on campus, as close as it
Right.
can be,
Yeah.
because we're going to want to do simulation and testing and mock-ups and things, and we know people from the campus are going to need to be a part of that planning. And so we want to have something that's close by that doesn't waste time with people traveling.
And we know you've already done 1 million studies, and we have dug through those studies, and we're gonna bring forward what's valid or not, but we're gonna need to validate that with your users and your leadership, so we can decipher information very quickly and make decisions to move forward. We got 9 months to get this right and set the platform for the future.
So just one more comment back on that entire group of people. This is the most experienced team I've ever been a part of. I mean, this is an incredible group of people.
So can I ask a couple more questions about the team? Give us some sense of who's gonna be here, boots on the ground, during this process, and who's gonna be working from Houston or Chicago or where else? Because some of the, you know, information we need is specifically relative to some of your very, very important roles, ongoing roles in this process. Who's gonna be in Fort Worth, Texas versus other places?
I've got the moving van in the driveway ready to come.
You're gonna tell your wife already?
And do you want to talk to this?
I can.
This kind of shows that.
I'll kind of jump right into this. So this is a little different than what you saw in our proposal. What I did was, I thought, okay, who is from day one to the end? And we had some scattered down here, so I shifted all those folks up, right? So this is the IPMO group, right? And that's represented on our org chart. So Stephen at Project Exec, me as the IPMO lead, we've got Tanya, Pam, and Kimberly. It's our hub MWBE folks. Ken Worrell, Senior Construction Manager. Jerome Stott, our Project Controls Manager. Andy Dermawan, Scheduling. And then Claude, our Cost Control Professional.
Most of those folks are gonna be here, right?
All of them are going to be here full-time. I'm probably the only one that, I'm full-time for the first 2 years.
So the darkest shading represents full-time resources. Okay. As the shading decreases, then that's a part-time. But I did do an FTE calculation, but we have several that go on now.
And where's Percival in that?
So when you get to the initial phase, all that happens here. This is year 2020, right? So the initial phase will be done at the end of this year.
Okay.
So that's.
So,
God bless.
Sam,
Yep.
you're doing the modeling, right? You're doing financial modeling?
Financial modeling, yes, working closely with Halsa, who's doing the strategic modeling, like volume projections, staffing.
So that's one of the things I was kind of confused about in the proposal, is I need to be able to differentiate who's going to be the person we go to ask questions relative to specific operational financial modeling that accompanies these capital expenditures.
Yep.
Because one of the issues that we've had is understanding we've got $1 billion+ in capital expenditures over the next 20 years. How that relates to our operational ability to fund that capital is a pretty important part for us. And I'm reading from the proposal, if I'm right, you and Halsa are both responsible for that, but how does that work together?
Well, there's different elements, right? So there's the sort of cash flows, pro formas, balance statements, sources and uses of cash, and doing cost estimate. There's other people on the team who are going to be doing those elements, because those sort of feed into the financial model. So some of that cost modeling is done by other members of the team, and that's more the boots on the ground piece.
So
And then,
who does that? Who's going to be doing that piece? I'm specifically talking about the modeling that shows us operational impact associated with capital expenditures, so that we know before we go out there and, you know, let a contract to build X, Y, and Z, that we've got the operational capacity to be able to fund it.
Right,
and
that
pay
would be
for it.
Halsa. Halsa's got a really big understanding of that, yep. They
Okay.
do cost modeling for operational.
Who at Halsa, Diana?
Kristen Anderson will be the point on that, and then Scott Walters will be her backup.
Okay.
They're gonna probably tag team full-time, I'd say.
yeah, they're going to
3
do
or 4
all the
days a week.
staffing and operational
Yes.
costs.
And where are they
cost
located?
They're in Minnesota, but they will come here.
So will we have someone on the ground during the first 9 months,
Kristen,
full-time?
Well, I don't know if she'll be here full-time, but at least 2 to 3 days a week, she'll
Okay.
be here.
Okay, all right, thank you.
And that's Kristen will be here 2 to 3 days a
Kristen
week?
Anderson.
Okay.
And if we need them here more, they're gonna be here 5 days a week. They know it's crunch time, that we have to get that done.
Sure.
Drop dead done, this is 9 months or earlier. We really selected the team that already has a big understanding and done a lot of studies. We don't wanna waste your dollars, so if we can get it done faster, we're gonna try. There's a lot of data that we gotta validate to right-size that bond
So I went through and I picked some of the IPMO responsibilities out of the RFP, and I mean, that top bullet says it all, right? I mean, we're gonna plan, manage, coordinate, and control all aspects of this program. That's a huge undertaking, and I don't think any of us take it lightly. And so, you know, how do we do that? How do we get there? And for me, it's the work that Mary Ann and Patrick are going to do to create a document that is our program implementation plan. So something similar to this, that it's our playbook from the beginning to the end. This is how we're going to execute this program. And with that, I'll let Mary Ann.
Well, on this same subject, as a matter of fact, the University of Mississippi Children's Hospital, it's a $688 million project right now that's going on. We had our initial pull schedule and, of course, spent a lot of time in interviewing staff and in the trenches, understanding not only their clinical needs, but the community, and tying that up with what's happening outside so that we can consider what the patient experience is going to be. But by putting this together, it actually holds folks accountable. In this particular situation, we are more than 50% through. We have 0 change orders. We are ahead of schedule, and we are under budget. We expect to bring that very same enthusiasm and the tools that we're going to use here. Brings all the vendors in under one channel. They're all funneled together. They follow the same principles. We align that also with what we know is that Tarrant County has their own facilities management playbook, your own policies and procedures and your manuals. We are going to integrate with you in that so that we are in line and in step directly with what you've got going. Along the lines of the process optimization, our approach is to have this core concept, to have a charter, to have everybody together and on the same page. How are we going to communicate so that it's efficient? We will identify which tool to use at the right time in the right place and pull that together for processing in the most efficient way. Leaning this out so that we can eliminate those wastes and deliver those predictable results. When we're talking about patients, we don't have time to mess around and make the same mistakes over and over again. But you're going to be learning from our over hundreds of years combined expertise so that we can map this out in a process that's going to optimize and get us to the end result in the most efficient way that we possibly can, and to work with you in that.
Skip.
And we'll come back to HALSA when they get here.
We'll circle back to, sure.
The book that you just showed us there.
Yes, sir.
Okay. That's your Bible.
It's created for individual organizations. This is a sample of one of which we created for a current project.
That's
University of
Mississippi.
Right. Okay, but that similar will be created for here.
Absolutely.
Yes.
Okay.
Yes.
How do you integrate that to the board and staff to understand that, to be able to go by that?
We will have steering committee meetings. We will have monthly communications and align with whatever your desires are to make sure that we are communicating the right pieces of information. And I'm assuming Robert's going to have a big role in that as far as...
He'll be flying around the country, I'm not sure.
Yeah, so it's not, we're not going to be off in a room by ourselves doing this. I mean, this only happens because we're meeting with you and figuring out what we need to make this program work. And that information comes from you guys.
Right. This is going to be one of 2 deliveries that we have for you at the end of the 9-month period. So we're running 2 streams on that full plan over there. One is about the process optimization and getting all the processes that are going to be used in the future second phase in that book. And then the first piece of it is making sure that we're right-sizing all the buildings, we know what the volumes are, we know what the payer mix is, all those things, so that whatever we decide to build, that's the map that we're going to use to get there. So there's 2 streams.
It's also a handoff to your facilities. You're going to get buildings, and your fiscal plant, Lou or his team, you're going to have to know how to operate those buildings efficiently, and that is yours. When we get done, that is your policy and procedure and your path forward. It's not just about this project, it is about, because you want help with picking the right technology. You want help to pick the right policies and procedures and processes.
Right.
So you have a wonderful whole department when we get done. This is a massive, 2 million more square feet that you're going to be adding, and you need to know how to operate.
It's going to be customized, absolutely, to your needs. Which means we're going to be spending a lot of time together. And one of the key things in understanding people is having the ability to really inspire them to speak up when they need to, and working with us from some of those same military concepts with project management and also behavioral scientists that we've worked with in cockpits of military aviators. We will be incorporating those very same team approaches to gathering that information. It's a good question. Thank you.
So let's pivot to financial planning a little bit, and when Halsa comes in, they'll talk a little bit about the operational cost modeling, which fits into the financial modeling. Actually, I first want to address Robert's earlier comment. About 6 years ago, I was doing an ambulatory network plan for Scottsdale Healthcare, had a C-suite meeting in the morning. About 6 a.m., my appendix burst, got rushed to the ER there, and had a quick surgery. So I sort of joked with them after that the money you made off of that kind of paid for our consulting fee. So you never know what's going to contribute to the bottom line.
How are your tonsils?
A little scratchy. I still have a kidney, no more appendix, but there's still body parts that
I'm
could
not
go.
being rude,
So.
but just let me text.
Yeah, I do feel a little hot in here, so I don't know.
Let's give you a surgeon's point of view. Everybody has 3 operations. It's just up to us to find them.
I've already had a couple, so
What do you say after?
So financial planning. And now if I pivot to the...
Yeah, where's your cockpit conversation go now?
The subject of cash flow analysis, income statements, balance sheets is kind of a pretty dry conversation, so I'm not going to get into the weeds of that. I actually like to use the term financial impact analysis, right? Because at the end of the day, these projects that you're doing are going to be transformational to your bottom line. By that, I mean it's going to change your operations, it's going to change your cost structure, it's going to change where your patients are being seen. So if you think about it, financial planning, a lot of people focus on sort of current state baseline, and that's absolutely something we're going to look at. That's how you base the financial models. But it's really financial planning, and I'm a big believer in the integration of strategic and financial planning, and that's why Halsa and I will work very closely together on this. It really needs to be forward-looking. It needs to be about how you project that going forward. So part of that, right, is risk analysis, and this is how you sort of create a sustainable, viable future enterprises by creating financial viability going forward. So we're going to examine financial risks, like these projects, will they impact district at all? What may change with Medicaid going forward? I know Texas has sort of toyed with the idea of going to Medicaid HMO, so what are the impacts of that? So we'll run some scenarios. You see scenario planning in that. We'll do some sensitivities analysis on that. The other part of that, right, is where there may be some revenue enhancements. How are these projects going to sort of pay for themselves going forward? And so when people think of that, right, they think of typically what they do is they look at services, they look at service lines. Which services and service lines have the highest contribution margin? Let's do more of those, right? That makes sense. And that's something we'll absolutely look at. But sometimes the other piece that people miss is let's actually look at your patients. What's unique about JPS is your payer mix is obviously much different. And I think a lot of consulting firms make the mistake when they come to an organization like JPS that they come from the nonprofit healthcare system world. They're used to sort of chasing commercial payers, et cetera. That's not what exists here, right? So when we look at your patients, number one, that doesn't mean there aren't opportunities for you, and they don't have to be commercial payer opportunities. Medicare, and I know this is something that Halsa did in one of their previous things, just a little bit of an uptick on that can have a huge impact on the bottom line. So we are going to look at utilization by payer mix on your service lines. That will be a big impact. Another one, the other side, not just revenue, right, is flipping it to the cost side. So if you look at where is the appropriate site of care for patients, you are expanding your medical home network. Those are lower cost settings. That gets people, if you think about value-based care, you want to be more involved in that. You want to change that, and that's something we're going to look at in this process. So next slide, you can see I alluded to earlier the prior work we did. I threw some of that up here. The first chart, what I did, and again, my role was a little bit different than that. I didn't do the financial planning previously for that project. What I did was ambulatory network planning. So if you think about your medical home strategy, Where should we put medical homes in our market? How many should we build? That was kind of the initial outline of the strategy we did. So one thing we did, and I mentioned, again, understanding your specific patient population is key to this. So we created a whole methodology, based on percentage of federal poverty level, based on primary care need in the market, based on different metrics that we use to then prioritize zip codes in your market, and that sort of fed into recommendations about where the next couple of medical homes should be built. And I know you opened one in 2018. That was actually already planned at the time we came on board as a relocation. The other thing we did, so that's network planning, right? But why is that important for the campus planning? As a consultant, we believe in a team cooperation, everybody working together. So I ended up kind of getting into the areas also of the campus planning. So how does that ambulatory planning integrate with on-campus planning? And so with that, one thing I did was, I poured through all the previous reports, the BOCA, the Broadus Blue Cottage. I even called up Blue Cottage and arranged a meeting with them so I could understand the assumptions that drove that plan forward. I think the good thing is there's obviously been a lot of work done. We're not trying, as you know, we're not trying to reinvent the planning wheel on this one. We're going to use, there's a lot of information out there. We're going to use that, and we're going to build on that. I did identify some gaps in those plans earlier that I think need to be addressed in that process, so we'll do that as well. I also worked cooperatively with HMA on that project, and so I sat in on some of their meetings, so even that wasn't my role to do the work they did. I sort of provided some strategic advice on that as well. I think one of the things I think that was helpful that I did in that process was when we were planning the behavioral health hospital. Those who remember that from before, it started out really huge, and I helped them scale that back a little bit. And to be honest, I think there may be some opportunities to scale that back a little bit for. So it's all about right-sizing these for your organization. So finally, the last part of cost, and I'm going to turn it over to Bob, because if you think about uses and sources of cash, there are other options that are available to make sure that this project's viable. So Bob's going to talk about that a little bit.
Yeah, I'd like to briefly just talk about public-private partnerships. And just from a philosophical standpoint, I just want to come, is we look at P3s as just new tools in the toolkit. They make sense sometimes, they don't make sense other times, and there's different natures of them. So the first part is, well, what can they potentially do on projects? Big one is risk transfer. Often a lot of public agencies, one of the real hard times is managing long-term capital renewal and keeping the facilities from getting degraded. And I'm making no comments at all on you folks, just a general thing we see. You can transfer that risk to the public sector if you can do it at the right value and contractually obligate them to maintain your facilities to a certain performance level. There's other risk transfers, design, construction, revenue risk that you can also transfer on some projects. But there's a variety of ways that, if you could back up really quickly, that you can deal with. You can also use them as an access to funding. It's an alternative funding source. Sometimes if you have an extra piece of land, you'd like to have a hospital. Next to the hospital, you'd like to have a hotel as a way to sort of support it. You might have a piece of land. You can not only create an amenity that supports it, you can also create a revenue source out of that through monetizing that in a public-private partnership. It's a way to transfer debt obligations, and sometimes it's a way to really unlock innovation of the private sector through performance-based specifications. So there's a variety of areas. Now if we can go to the next one. Up here you have a spectrum, and there's hybrids to all of these. Really, on the left you've got traditional design bid build and design build and things that have been a delivery mechanism for a long time. Over to the right are the public-private partnership structures. There's really three fundamental ones. The one that first came to the U.S. and it's been done in the UK and Canada for a long time is the design, build, finance, operate, maintain concession model. Potentially it's a way of transferring risk of a whole variety of different elements, but it comes at a cost. May make sense, may not make sense. Hard to structure with tax-exempt debt, so there's a financing issue where there's other opportunities to do that. There's also three-party vehicles where you can get some of the benefits of the design, build, operate, maintain, and still preserve nonprofit debt. And then there's a two-party, which is really used to monetize assets for a way to kind of put productive use of your land for an amenity that supports the institution, but also can generate revenue. And sort of our charge on this is, as capital projects are coming over, use these filters as one of the analysis factors to go, does alternative delivery make sense or not on a given project? And this can go to a tremendous amount of things. We're doing a wastewater treatment plant right now. We're doing a power plant for University of California, Fresno. And so it can be both on the heavy infrastructure as well as on the buildings and facilities. And so our role in the team is sort of deal with that. And if we go to the last slide quickly, and really, this just is one that kind of shows some of the risk transfer spectrum that happens between some of these different structures. And what we think that transfer of risk is a key component on a complex project, that this is another filter to sort of evaluate something before you commit to a capital plan to look at, are we balancing the risk in the right way between ourselves and the providers? So thank you.
Now our special guest has arrived. Thank you for coming.
My apologies for my tardiness. We had a
Go ahead.
commitment in Oklahoma City, then at between 7 and 8, so I got here as quickly as reasonably safely. So,
You got out of Oklahoma, that's a good sign.
Glad to be in Texas. Scott Walters with Alsa Advisors. My partner Kristen and I will be very heavily involved in the engagement. We're a small firm, so we don't have a marketing team. The people who sell the work are the people that do the work. So if you don't like the partner that you see here today, I don't think that someone else is going to be showing up to do the work, because there is nobody else to show up to do the work. There'll be 4 of us that'll be committed to this effort. The key elements that we bring are the strategic planning, so looking at the demand modeling, capacity forecasting concerning the demand, clinical volumes into the required key rooms, and we will be looking at both the medical surgical components as well as the behavioral health, the psychiatric components. We think that's actually a strength that we bring where you can't neatly separate those two. So having the behavioral health and the psychiatric components as well as the medical surgical and the integration and the ties between those we think is a strength. We'll be doing, we start out with what we call hypothesis testing. So the first thing that we'll have is we'll identify probably 4 to 6 key strategic hypotheses that are likely to be the biggest drivers of the success or lack of success of your projects. And we trust that you already know probably what those big questions are. So instead of just doing a lot of analysis and kind of trying to boil the ocean, we'll focus our time on those 4 to 6 key questions. And we already have a few guesses at what those are likely to be in the slide deck. And we'll talk about those. But, that's really helps us very quickly get into those key issues, focus our time, focus the data around those key issues, get to answers on those key issues as quickly as we can, and then use those to drive the demand modeling and really focus it on the projects that are really going to make the most sense, have the best return, help fund the later projects, and make sure that you have a strategic framework that you're aligning all of the projects with and kind of hanging all of the projects on that integrated strategic framework. So here are the kind of those 6 observations that we've had so far. First of all, anytime you add this kind of square footage, you will be adding cost to the cost structure. Attracting additional incremental funded patients are how you cover those incremental costs. It doesn't take that many to make a big difference. And one of the biggest opportunities to capture those is age 65. Every single time one of your patients turns 65, they qualify for Medicare. If we can craft some strategies to hang on to those patients, every year we're going to capture more and more funded patients. So it doesn't necessarily have to be a competitive program. We'll be looking at opportunities to reduce inpatient utilization, but we have found that those have been overhyped and over-advertised, and if you're counting on Pop Health to reduce the demand for beds significantly, you are likely to be disappointed. We've been promised the transition to outpatient for 20 years. Yes, outpatient has been growing rapidly, but we have not seen big declines on inpatient discharges or inpatient days as quickly as they've been promised. It's very hard work, and we're doing that hard work with a population that is harder to work with than most. On the plus side, a win, we found that length of stay reductions when you get from a mostly semi-private to a mostly private room environment can be substantial. It can be about a quarter of a day simply by getting into a more private room environment. About 2/3 private rooms is where you get that pickup. We're below that today, so just by the virtue of getting to private rooms, we should see some pickup on length of stay. Ambulatory surgery centers, especially trauma centers, very inpatient-focused hospitals. Everybody's always in favor of the ambulatory surgery center, but they're usually in favor of it for some other surgeon. If we can get all those ambulatory cases out of here, there's plenty of room for me. So we've got a methodology to go through literally surgeon by surgeon and really identify the ones who are likely to want to move their practice to that ambulatory surgery center environment, which sets it up for a better opportunity, better likelihood for success. We saw the plan for the 300-bed inpatient psychiatric hospital. That concerns us right off the bat. Just that degree of growth in that program, the operating cost implications of that are going to be huge. Your population is going to be a more difficult to manage psychiatric population than kind of the general behavioral health population at large. And our expectation is intensive outpatient partial hospitalization might be a better use of some of those resources, give you a lot more bang for your buck, but we can dive into that a lot more deeply. And the key issues between, part of that driver is that psychiatric and medical patients, their problems are not easy severable, especially when you're looking at a large public teaching hospital. The kind of freestanding behavioral health hospital proponents, consultants who specialize in behavioral health and psychiatric hospitals are typically much more familiar with the community hospital type patients, and those patients are a very different set of individuals who are, the more run-of-the-mill depression, anxiety type disorders versus the types of disorders that we're likely to face where people are, threatening, can be abusive to staff, and you need a very different facility response and a very different strategy to deal with some of those patients. So that's our story.
Quickly.
Well, I'm going to jump into the stuff that I love, which is master planning. So being an architect, I've Tarrant County resident for over 40 years. Our office is about a mile from here. So I drive by every day, look at JPS every day. So for us, the best thing that we can do is describe master planning, in this case, like patient care. So the first step of it is to really look at the history of it. So we're going to dig into all the information in the past. We're going to go through the Blue Ribbon Committee reports. We're going to go through all that and really understand what the intention was and probably ask some few questions to get clarifications. We're going to need to establish the goals and objectives, the financial framework of what the master plan is. But the most important thing in this step is we're getting to the benchmarking. This is where we're kind of setting the stage of what are the expectations of the board and JPS coming into this project, so we know as we move forward what that benchmark is. The next step in this would be kind of like with a patient, which would be a patient's current status, their health, things like that. So what we want to look at the next step is to step in with JPS, look at where everything's at today. This is where we start to build the program, but we're going to do, I say, facility assessments. So we're going to look at all the buildings, get an understanding of what's there, what the department makeups are, what the bed counts, kind of go through a big breakdown. The other thing that we want to do is we want to do process mapping. So one of the things we'll look at is current state maps. So we want to look at a patient as they enter the ED, for example, and what's the steps that they take going through the ED and all their touch points. And then we want to look at, is there something that we could do, for an example, with that, a future state mapping? So how could we alter that flow of the patient to change or to improve their ease of access in the system and make that process more efficient? We're also going to look at patient experience mapping. So we want, as the patient walks in the front door, what's their experience going to be? What's their ease of access into this building, this hospital, or any of the other outreach areas? And then the last piece we kind of want to talk about here was just some opportunities that we see on the existing site. So we all know that there's a cemetery just north of the hospital. There's also a giant railroad. Currently with the state of Texas, they don't like hospitals being built by either one of them. So that is a conversation that we will have. We'll also look at the impacts to Main Street, mass transit coming into the hospital. We've also got, as the proposed expansion is now going north on the master plan that's currently created. As we all know, it goes over the loading dock, the ambulance century, but we've got one other opportunity there. Right now in the patient pavilion, all of the public traffic and flow is on the south end. Everything from the north 2/3 of that building is all patient care. It's not easily to cut through. So as we put a building to the north, we have to account for how patients are going to move through that. The third step is planning. So in the planning step of this is where we really start to compare opportunities and come up with alternates. So you can kind of see on the right side of the screen there, there's actually 4 options, A, B, C, D. Those are all the same program, but they're different options of how it could be set up and laid out and responded to. And I think with that one, what we do is we go through what we call a choosing by advantage or a CBA process. And so we can set up all the options, we can go through the pros and cons, and then we can score them based on the goals of the project. So that way we all know as a team that we're moving forward with the right options, that's the right thing to do for JPS. We're also going to look at, very importantly, national patient care delivery models and how those are trending and where the market's moving. We're going to look at the adaptive reuse of your existing buildings. So there is a lot of buildings sitting here that we need to look at the opportunities of what can we do, I want to say with the buildings that could stay, or what are their opportunities as well in the future. We'll also use national benchmarking as well, just to look at the key planning units, room turnaround times, lengths of stay type items. And then, of course, the last piece of this to compare to patient care is to look at it, that this is where we're going to execute the plan. So as we've gone through the patient, we understand their current status. Now we're going to execute that plan for their care in the future. And it's the same thing here. So we're going to take that preferred plan option, we're going to document it with the capital development and the phasing plans and produce that final campus and system master plan.
Real quickly, because I know we're running short on time, a little bit about utility master planning and the role it's going to play. Really, the goal of utility master planning on a campus like this is to minimize life cycle costs of major investments that you have to make that don't either heal a patient or generate revenue. So the goal here, and we've done it very successfully, one of the slides up there, you see TICO, that's in the Texas Medical Center, I think the largest chiller plant in North America. We helped them save $200 million over a 15-year period just by implementing new technologies or innovative technologies like thermal storage, cogeneration, high efficiency chillers and things like that. So that's real money that begins to then be available for other operations. Other project I'll point out at the top of the screen is a boiler plant that we did, P3, in New Orleans for the new University Medical Center there. Serves not only the medical center, but also community colleges and private clients, private industry down there as well. Just tagging on to what Bob Bettis said about P3s, this is a good candidate for that. Thank you.
Okay. As I've listened to the presentation, I've heard there's a lot of brain power, there's going to be a lot of computer power, there's going to be a lot of different issues to deal with. But when it comes to cost control, there's just one simple bottom line, and that is it's our duty to avoid, no matter what the construction delivery is, that project on bid day doesn't blow up on you. And that's the bottom line. Because if projects begin to blow up on you, your money is spent, you've had a lot of issues. So what is the first thing for that? The first thing, and here's where the big room comes into, is that our team needs to be at the beginning to understand the scope of the project 100%. Once we understand the scope of the project, we then cost that scope, okay? That's going to give you the first indication of where you are in terms of your budget and in terms of where you are in terms of scope to budget, okay? Since we're going to be on the program side as cost estimators, what we're also going to be doing is looking at the milestone deliverables from the AE teams and the contractors. It's going to be our goal at each design deliverable to look at specs, to look at drawings, and to make sure that as cost estimators, we're estimating a project just like a contractor would. Are there any uh-ohs in the drawings? Are there any potential change orders, because that's one of the critical things that we need to look at. The last important aspect for what we will be doing for you is also being involved in what's called reconciliation, okay? At each phase, there'll be a reconciliation. There'll be a contractor that develops an estimate. Might be an architect who develops an estimate, and we'll have an estimate. And then it's going to be our challenge during those reconciliations to make sure that that project stays in budget, to be able to challenge if we see inefficiencies, if we see anything that's going on with the process, to be able to challenge that. It's for us to let you on a cost basis to understand reality. Why? Because if we don't give that to you, over a 10 to 12 year period, you could run into financial issues. So our challenge is pure and simple. Make sure in real time that when that project hits the street, you're in the money. Thank you.
Let me ask you a quick question about that,
Sure.
because what I didn't hear, and not that it's bad, just maybe can enlighten me, is reconciliation is one thing. My question is can we afford it? So how much do you go back and work with our team? Because we can have a really pretty decorated Christmas tree, but if we can't afford it, I don't know how much we want to tell the community about how pretty the ornaments are. So to what extent do you work with our team and say, you don't have this amount of money, or you can't afford the principal and interest on this amount?
That's what we do every day, all day, okay? As I'm pretty sure everybody knows in the room right now, due to this economic growth spurt, keeping projects in budgets are very challenging, okay? So one of the things that we've been doing for 10 years, it's called value engineering. Now, on this level, value engineering means your project was 10 million, looks like it's 15 million, what are you gonna do? Okay, so it is our challenge then to work with you to say, all right, what can we do? What can we do here to use different materials, to look at different processes, to look at different HVAC systems, electrical systems? What can we do to maintain the value of your project and keep you in budget? Okay, and that's what we do every day, all day.
Are you, and I'll stop after this line of questioning.
Go ahead.
Are you willing to not allow that project to even go forward if you don't know we can afford it? Because the explanation that you just gave, which is a good one, but the project's already out there, it's a $15 million project, you all can't afford it, we'll figure out ways to get you down to 10 million. I'm not sure that I want that sex appeal out there if we can't even afford it. So are you preliminarily getting to that point to say, we're not even gonna bring projects up that cost $15 million, even if we got it to 10?
Okay, now, the question you're asking me is a very interesting catch-22 that we deal with all the time.
That's what I like to do.
Okay.
That's what I do.
All right. First of all, as a cost estimator, if we're working for a design team, right? The design team's motivation is to keep this project moving along because there's money to be made here. So we have to have, and by the way, I'm only 25 years old. It's stress that has me looking like this. What we have to do is we have to be able to speak truth to power. All right? So lots of times, especially in the government sector, because that's what we do, DOD and other government sectors, we're constantly having to bring the reality to bear. That this project is over budget. Now, some independent cost estimating firms, because they're paying us, will throw it under the table, but for us, it's an absolute no. Basically what happens is, if your project will get out of budget from day one, that scope to budget, and it's for us to make sure that we tell you what that number is. As the design progresses, and we see that maybe there's some user items that you want to interject into the project, it's up for us to tell you what that cost is. The bottom line is this: if we're honest with you and with the team, and we deliver the information, hey, there might be a spike in the economy. As long as we're honest and as long as we give you that information, it'll be up to you to make that decision.
Can I add one more thing to that?
Sure.
One of the methods that we're going to use is called target value design. Ken and I have done this all the time, and we used it at Cuuck a lot, is there's always good, better, and best when you're talking about facilities, right? Depending on what type of systems you use, what type of materials you use. We're gonna know with very limited information that Scott and some of the other team members give us, that we're gonna be able to produce these budgets within days of being on your campus. We may not know what all the variables are, but we're gonna be able to at least say, okay, here's where we are with good, better, best. We're gonna know what the target is, our designers are gonna know what the target budget is, and it's gonna be our job to manage them through that process to make sure that we stay on that target. And when there's deviations to that, that's when we're gonna come to you and we're gonna be able to tell you very early whether or not we need to make changes to that. So there is a system that we will use called target value design to try and keep everything in your program within the budget.
Right. Well, for us too, that helps us, as long as we have a standard for a campus, for example, what we're doing in EP systems, material systems, it's easy to project those things, and so you don't have changes of unknowns or say other items like that. And as things change, there's a way to evaluate that, because what we're really gonna look for is how do we add value, not decrease value. And so that's what that process will kind of walk through as well to avoid that. And it really has to do with just being transparent and understanding what the expectations are.
And I think the way we have the big room set up and the lean methodologies, I as a clinician in a user group, I always hated the fragmentation. You would sit with the architects and they'd let you design. Markla and I go around and around about that. They let me go. It's like dream big, docs come in, want this, want that. And nobody tells me about an ROI until it's 9 months into design. And then I do have to VE and I lose program. And that is devastating to a clinician. We need to know right up front, and the way we've got integrated delivery, we're gonna be right at the table with the architects, and it's gonna be transparent from strategic planning over to master planning and integrated approach. Because if it doesn't, we don't have time to mess up. We can't wait 9 months before you tell us the truth, right?
Yeah.
The users need to know, and now make sure of it, because I've been burned over the last 30 years, and I had these big dreams of things, and my program just shrunk in half sometimes, so.
Yes. What I've noticed is on our value engineering exercises, when you bring in an independent team to look at the same project, because the architects and engineers have been looking at it over and over again, there are always options, especially with HVAC. Do you want to take a cap hit and have a very efficient HVAC and try to pay for that over the life cycle cost of the facility? Or you got budget restraints, so you need to go back to the tried and true VAV systems. Okay. But then also too, and I don't know if this is a strategy that you want to use, but often when projects are experiencing budget issues, what we do is we develop options, bid options, right? So if the project comes in on budget, plus all the options, you got it. But if the project is a little over budget, now what you can do is you have options that you can use to help keep your project in budget and, more importantly, buildable.
And we can identify those strategically right up front. So here's the first thing that I peel out strategically. This piece can wait. What you've got today is less bad. You can live with that. This piece has to go first. And, we can right up front start to layer in some of those opportunities.
And I think just one final thing is that this is why a collaboration with your stakeholder teams is so important, because we want to vet this early with you so that all of a sudden you're not throwing a bunch of unrealistic designs out there to the world that can't be afforded. And so it's aggressive, it's interaction, and there's always tough choices that come through it. But where it doesn't work well is you let the architects run all the way down to design development, and you finally take a look at it, and you've lost all this opportunity to kind of do those options. And so it really involves a collaboration with you folks through this process. We have, even in this tough area, very few times have had budget bust when you do that, because you usually make the hard decisions up front rather than when it's a big ugly bid opening.
And I want to add something as far as finding out about the budget. Our team will respect the users. I always felt kind of like in the dark all the time, and we're not going to be that way. We're going to tell the users, we're going to tell the nurses and the doctors, you can't add 3 more ORs. The ROI will not pay for itself for the life of the building. And we're going to make sure you know that up front. We'll speak in lay terms. They'll speak in lay terms. We'll make sure of that.
Just quickly too, because part of your question was about what we can afford, right? So early on, we're going to be evaluating cash flow, cash reserves, debt capacity. So all of those things will sort of shed light on what you can afford. And if the $800 million bond or other cash resources aren't enough, we're gonna try to identify that early on. And then when we do value engineer the project, or even when we develop the project, we're gonna look at the costs of that and sort of see how that fits in the picture. Also see how that cost potentially will impact that cash flow going forward. And so today's cash flow and cash reserves and cash availability isn't necessarily what it's gonna look like in the future. So that's something we're gonna try to identify early on. Although that will change during the process as we get into the details of it.
So
I have a
go
question
ahead.
for you. Will we, as board member and leadership, know the trade-off when you use those options? Because sometimes I've seen people put equipment in, but shorten the warranty period, and then everything else rolls to operating expenses down the road.
Then you pay for it in the back end, you really don't get the value, yeah.
That trade-off up front, so that we can make that kind of informed decision, because we wouldn't know if things just come up and then we just approve them.
Absolutely. I mean, this is a team that believes in an open, transparent book dialogue. Ultimately, we don't ever forget, this is your hospital, this is your facility. And those are hard decisions. The life cycle decisions are a big decision too, because it also can get an amortization and financing. Because you may have something that, that's 20% more upfront, but over the life cycle is going to save you 50%. And we want you to know what those trade-offs are, and sometimes you can deal with that with the financing package to kind of level that out. So there's lots of different tools that can get you there. But it only works when this type of dialogue is going on all along in a project. Yeah, so it's not like just the brain power of this team just goes, oh, we've already done it, you should do this. This is an ongoing dialogue, both at first cost and life cycle cost, and even how you set up competitions. Because we had a very successful competition for Colorado State University for a large animal hospital and a teaching facility where we didn't think they could get it. We were competing with a couple of developers in a life cycle, so we said, well, we're going to set an upset limit that if you can't hit this target, you will be non-compliant on your bid. But it didn't have everything they want, and then we had what we called a scope ladder with a whole variety of other things that they would like to have, and the competition was who's the lowest price, it's who can give us the most scope for the price. And that competitive set really drove that and ended up getting them about $7 million more than they thought they could.
Yeah, and here's an example, just one simple thing that can improve being able to budget your project. I'm an MEP estimator, so I see a lot of his work. And one of the things that is critical is when, during the phase, SD, DD, CD, when do the pipes get sized on the drawings, okay? If that doesn't happen until 65%, 95%, when the size of the pipings first enter the drawings, what does that mean? That means that the estimator has had to make assumptions all the way through. He now can do the actual calculation, and you get a, boom, the cost has gone up. So one of the ways to mitigate that is to ask the have standards for each deliverable from the design team. Make sure that pipes and schedules are completed at DD. Because if you don't do these little things, that's when the cost can jump up on you.
I think that's a good segue for you.
All right. So, speaking of cost, I'm going to go backwards on this one. So, what we've done with Claude and Andy, our scheduler's help, we have actually loaded the cost. We took some guesses at rough order of magnitude cost for the program based on the projects that you listed in RFP. And we have started to load cost into the schedule. And so, right now it's not perfect, but this shows the expenditures each quarter as we go through the program. So going back to where I was going to go, we took your schedule and we actually put it in Primavera P6, the activities that we could see. Because we recommended this is the platform that we use for scheduling, not only for the program schedule, but require the contractors to use it as well. So as we go through, get this cost loaded, we'll be able to see what's happening with the cost and check it going into the future, see how it's trending. I think this is really going to help us with mitigating budget risk into the future. And I know we're running short on time. The only other thing I wanted to throw in there, and Robert's left the room, this is a pretty boring board, but I see celebrations in here. We've got about 12 buildings that are clinical in nature. That is 24 celebrations, groundbreaking, grand opening, and it occurs almost 10 years, 24 celebrations over 10 years, where we can promote JPS. Yeah. You know, the transformation to a world-class healthcare institution delivering excellent care to their patients. So, we've been talking a lot about this. This has been all these conversations were the initial phase, the first 9 months. So at the end of this first 9 months, what are you going to get? You're going to get a final report from us. It's going to have the strategic plan. It's going to have program baselines for scope, budget, schedule, pro forma. It's going to have your program requirements that designers are going to need to know about. It's going to have collateral material for the sale of your bonds. It's going to have what Mary Ann is going to produce, and that's that program implementation plan, which will be the playbook for the entire program. And so we've talked about this. Do I need to go over it again? Okay. And then, so then we're on, the first 9 months is done. Then we're on to the traditional design and construction type arrangement where we're going to lead all the teams. We're going to procure consultants and contractors. We're going to go through that all the way to the program is completed. Here's a few examples of some of the things we're going to use. And this will come from Mary Ann's work of design and construction process maps, where it lays out what you do through the course of the project. Talked about communication. So monthly or whenever we decide, you guys will get a status update. Where are we? Budget, cost, schedule. You're going to know because we're going to be constantly sharing that with you at whatever frequency we decide.
So we wanted to be sure to mention some of the tools that we consider vitally important to integrate, and that is, of course, technology. Understanding some of the cutting-edge technology that's out there, we want to be able to bring those together so we will have a platform that coordinates and allows us to be the most efficient in our communication and the data management and the Internet of Things. BIM is one, and you'll see a whole list of several that we're very familiar with, and make certain that this platform is not going to be siloed, and it's not going to require that you buy only their batteries or have that. It's all going to integrate very well. Bottom line then, it allows us, all vendors and everybody, to have that straight shot, and when we click that button, it basically goes straight to accounting, and we've been able to basically pay the vendors in 21 days, and that keeps us in good favor. That also allows us to be much more efficient. So that's part of our approach to integrating the technology throughout the program.
And other value-add services, JLL has been around for, Steve said, 200 years. We have multiple services that we can offer. We can do menu of services, but one of our differentiators we feel are the clinical staff that we have on board. We can do medical equipment planning, transition planning. If we don't actually execute the work, we will provide oversight and keep those folks in line and on budget, and work with the user groups. It's very important to transition these buildings with simulation labs, modeling, so they meet life safety codes and they meet ICRA, PICRA, expectations from Joint Commission and Medicare. Goodness sakes, we probably, between us, we've been around a while, have probably 40 or 50 Joint Commission surveys under our belt.
Right.
Also, another really important thing is that we do grant writing. I think I mentioned earlier, I do construction grant writing and transportation, Mary Ann as well, and fundraising. We are in. If we are your partner, we are in to help you. And some of the fundraising that we've been involved with, I help raise money for transportation for the shut-ins. Stephen has a tremendous background on building an event that's local here in town. First year he did it was $30,000, and to this year to date, it's $300,000 a year. And you know, we could use something like that to help support transportation and access to care. So we're your partner. We'll work with Tanya. We'll work with you as a partner to see what your needs are, and see if there's something we can do to help build your brand in the community. Client first, I think I mentioned it sure that I interview, if Trent's involved or Charlie's involved, I'll meet with you on an individual basis and do a check and balance of our team. On the objective point of view, I am not a builder. I am passionate, I'm a clinician, and I want to make sure that these guys are held in check. We'll re-engineer how we're doing things, and we're going to be very proactive. Minimal, you'll meet with me through the first year is 3 times in the first 6 months, and then I'll do it on a quarterly basis, and I can switch it around, and I can meet with Dorothy if needed, or whoever wants to meet with me. Branding, I talked about that earlier. We have a separate division that helps with branding, wayfinding, and decreases your costs. We have our own GPO, basically. We've got how many locations across the world where we can buy equipment and we can buy FF&E products. And I don't know if it is as great as your GPO, but we'll do a check when it comes to purchasing items that you need to support your facilities. The other thing that FM, facilities management, we got tremendous capabilities with our engineers across the United States. We are kind of the benchmark when it comes to driving down cost of operations. And we know if we build these buildings, I used to have to budget an extra 30% in my operational costs when I added a new building. I had to get more staff, I had to add more costs to operate that building. So we have experts that will help minimize that cost. And then research, we are proactive. We understand we're trying to future-proof our decision-making, or not our decision-making, but our knowledge base. So when we sit down with you, we can offer you the national benchmarks across the world that works, lessons learned that work. Gosh knows how many years have we all worked together, and how many years we got experience. We've got a lot to offer to prevent you from rework, leaning up the process all along the way.
So
Yes, sir.
When you mentioned GPO, equipment, all that stuff, we do have our own GPO. So how does that work? And how do you guys handle just certain things? We may have rebates afterwards.
Yes.
And the price may be the same, but the rebate may not be the same.
That's right.
How do you
We
guys
have specialists that will analyze that, and they already have cost models where they can look at what they probably know what your rates are, and then we'll do a cost comparison. We can buy something more economical than that, and we'll make sure it's the same warranty, et cetera. Whatever your goals are, we'll do a comparative analysis.
As one of the world's largest facility managers, we do a huge amount of purchasing just within that, so that's the cloud. And it's just something that's offered. If you get a better price from us, you can do it. If you've got a better program, keep doing what you're doing. It just is sort of a value-add service.
It's just a check.
Will we know that the finance committee know which one is part of the new stuff, old stuff, ongoing, so we can
The existing state of the,
current business and ongoing at finance?
however you need us to report it. We've got expertise like, oh my goodness, I've never seen such robust capabilities. I have it, and I'm a nurse, and I'm impressed, so. Anyway. Stephen?
I'm glad Robert walked in when he did, so.
Oh. Yes.
We know poor planning is gonna deem poor results, right? So we've purposely put this team together to avoid those pitfalls of poor planning. Own it, seek joy, don't be a jerk. We've heard those words. We're gonna emulate them.
Super.
And we've put our team together knowing that we're gonna execute your mission. And in many ways, we've already started doing that. So thank you for having us today, and we are open for any question that you might have.
You put the team together. How many of you have worked together on other projects? Have you?
Gosh, we had a slide. I'm the oldest, so I've raised that one and that one and that one and that one.
I personally can tell you that I've worked with this gentleman. I've worked with Scott at Cuuck's a long time ago. And in our proposal, we actually have a matrix that shows how many months we've worked with each other on different projects. And you've worked with Halsa. I mean, it describes it in there, but it would be hard for me to tell you exactly. But we've all had a touch point with each other, at least on one project.
What work will the MBE, WBE be doing with your contractors, your minority contractors, as far as preparing them ready to, on the bid process?
So,
or qualifying them?
So Pam,
Well, Pam will set up diversity outreach to all, she's connected to all of the chambers, all of the organizations that we need to reach out to. But we We've assigned over 31%.
We have 31% with our
Just
initial
us.
team.
Just our
And then
team.
we know the goal of 25%, once we get into actual projects and some of the second phase stuff.
Yeah, the AECs also have.
But we will
to do
have a
that.
So
compliance
we'll be looking for the architects and engineers and contractors all to be participating just like we are.
We'll have, each program or each project will have its own hub subcontracting plan. Okay, it's project specific that addresses your goals. And when we go out into the market, or when those contractors go out into the market to seek subcontractors, they're gonna have to advertise and via the right agencies, use the right protocol to be sure that everyone has had an opportunity, qualified bidders have an opportunity to bid the work.
And we have full-time staff for the entirety of the program that's going to be managing that for us, and that's Pam's team.
And just add one more item. Jerome Stock, you saw on the board, who leads project control. Jerome Stock comes from construction, from the industry construction. In fact, he was a pre-con for Beck, you know, the firm Beck. So one of the things that he is very, very critical for is he knows the construction world, he knows the contractors, but he also had to do what was, for many, many years, is outreach, because that's part of the process of what contractors do. So we have a list of minority subs that have worked, all that information that we will readily give to this team so that they understand the lay of the land. And of course, Jerome's from Fort Worth, so we know Fort Worth.
And if you look at our breakdown, we've got nearly 14% hub participation in our estimating department, open challenge with Tanya and Pamela here, it's nearly 16%. And then we have an architect that's joined Michael's team, and he will help, it's about 0.25%. And then we also have MEP consulting, Adam Lamonti, he's got about 0.4%. And that's just our team, like I said. We'll hold.
Al signs and Multitech also.
Yes.
HB, FC.
Yes, and I'm not doing a really good job of this, but we're on a gag order here, because your rules, she can't speak, that's over our limit, but I'm trying to do justice to you, madam.
Doing some telepathy over there.
She has guided me every step of the way.
I've got a question. Having been involved in existing and new building processes before, are you guys going to look at holistic integration as a part of this, so that we take the old and the new and make them so that they flow? Or are we going to be talking to some of the patients to get their feedback about what's going on?
We're going to want community feedback. We're going to want to meet with people that are users, community members, just to make sure that we understand.
Focus group.
And
Her and I
then-
are gonna
and
work
then it's
together on,
what we discussed about earlier as part of the master planning, just looking what, reuse we can have for buildings. You really want to have a good flow between outpatient and inpatient, and so we're going to look at what plans have already been put together on where maybe the patient care center goes. Does that change? I don't know. I don't know the answer to that today, but looking at how patients' experience is from the moment that they are traveling to this facility all the way through discharge, we're going to take a look.
And or not, we're gonna walk in the steps. Like my background, I know there are patients out there that can't get here. And how do we get them here? We're gonna look at transportation. Our real estate analyst, David's not here, but he's gonna look at site analytics. He's gonna help guide and re-look at where you're gonna put your medical homes, make sure they're in key places. We're gonna look at your data to see what type of services need to go in the medical homes as they evolve through the evolution of the changes in reimbursement. But it's critical that we reach out to the patients, we understand, we walk in their shoes basically.
Absolutely.
We'll get on the buses and we'll ride the buses.
Work the night shifts, put on a pair of scrubs,
Yes.
identify what's happening, and remember the things that have occurred to us. I lost both my parents because of errors in medicine, and I have a passion that burns to make sure that we are paying attention to that patient experience and what the outcomes are going to be, are going to make a difference.
Well, I've said it several times in the board meetings, but there's two buildings in this world that I can get lost in. One is the Pentagon, and the other is JPS.
It's so important.
Would you know which one you're lost in when you're lost?
Well, you walk in the door and it says either JPS or Pentagon, so
Okay,
yes, I
good.
would know that,
Just to
even
make
if I'm
sure.
an Aggie, okay?
I think that's a good point though, you do spaghetti diagrams with you, Dave.
Yes, which we did show earlier, that we will go through that current also to talk about too is that's why we want to get an assessment of all the buildings, not necessarily a full condition assessment, but what are the spaces there? Can we adaptively reuse them? So if we move all the inpatient beds to a new tower, well, you've got a giant tower that's empty. So what can we do with that possibly? What are the opportunities there?
Okay.
Thank you.
Thank you very much. For the board, if we could just wait a couple minutes and let them get their stuff. Yep, please.
Are they bringing us lunch in?
Thank you, everybody.
Rodney,